i gwesteion bore yma. So we have Amor Pandit, Rodri Edwards and Ashley Callahan. Morning everyone. I am Jan Williams, the chair of the board of Swansea Bay University Health Board, which is the governing body of the organisation. A very warm welcome to the board meeting this morning and a particular welcome to our guests. We have Amor Pandit, one of our consultant urologists, who is here observing for the day, and Rodri Edwards, one of our consultant geriatricians and associate medical director, who is here for the consumer issue, and Ashley Callahan, who's just joined us as the Chief Business Officer. So, Professor Mel, if you gave a very warm welcome to you all. So, as I said, the board is the governing body, and it's the highest level of decision making for Swansea Bay. We are entrusted with the stewardship of £1.8 billion of public money. We have 12,800 whole-time equivalent staff, and we provide health services for 400,000 people who live in Swansea and East Portora. And this does make us one of the largest public bodies in the United Kingdom. We are a strategic population health body, and we have a statutory duty for public health and health protection. And we do have a specific population health committee, and we always apply a population health and wellbeing lens to our work. We also have a statutory duty around patient safety and service quality. Now, the whole board has a collective responsibility for patient safety, but we do have 4 clinical board members whose role includes alerting the board to any patient safety concerns. And we've had such an alert in the form of red flags around West Ward in Porthainen and patient safety issues associated with it. When the board gets red alert, the board has to act swiftly. And we did take at a special board meeting on the 11th of September a paper on this matter, and we gave approval in principle to start planning for the transfer of 30 beds in that ward to a 30-bed unit in Binghamton Hospital. And today we are looking at that matter and taking a final decision. And we are going to take that first on the agenda today. So this is one of our regular bi-monthly board meetings, and we do cover the breadth of the board agenda. And it's a formal platform for the board to hold itself accountable to the public. Open government is very important to the board, and we set out to be as transparent as we can be and to explain in full the rationale for board decisions. We work to 3 time horizons: the long term, the medium term, and the here and now, although some of these timelines do cross over in the decisions that we make. We work through a number of committees who do a lot of the detailed work on behalf of the board, and our papers will always include update reports from the committee chair. One of the things the board does is always triangulate performance, finance, safety, and quality. We will never take one at the expense of the others. We may have to give specific focus to one of the elements, but the others will always be in our frame. The board has to keep a future focus in line with that longer term look. So we are responsible for setting strategic direction and also for building and sustaining strategic partnerships, because so much of what we do is done in collaboration. And we have introduced earlier this year a new report on planning and partnerships that sets out that strategic agenda for us. Some of our partnerships are statutory, some are voluntary, and they've developed because of our commitment to work in collaboration. The report today includes an update on how we will take forward the refresh of our clinical services plan next year. And that is assuming an ever greater importance, because the scale of challenges facing the board and the organisation is significant. And we will hear the Chief Executive and Director of Resources talk throughout the meeting about the significance of the change agenda that we have to face. There are huge opportunities for us, but that will depend on the board taking courageous, ambitious decisions over the next 3 years, because we have to return to service and financial sustainability and balance. We will also look at an aspect of our work around commissioning today as well, and we'll take an update on the Area Planning Board and the Commissioning Alliance around services for people with substance use issues. So we always look at our strategic risks. Each of our committees will keep the relevant risks under consideration. The board is at work currently looking at our strategic risk appetite. We will be looking at this in a development session in October and bringing this back to the board in November. So in line with the here and now, the board always scrutinises delivery against our in-year plans. And this is a hefty section this time because we have some really big items on it. Our winter plan, proposals for a single regional pathology solution. We're looking at community pharmacy as well as part of our ongoing rolling programme around primary and community services. We always have a section on our people because we are a workforce-led organisation. The board is very keen to ensure that people can come to work and be their best authentic selves, that they are not subject to disadvantage or discrimination in any way, and that they can speak up safely. And our board agenda today does include, for noting, the annual report, the latest annual report on speaking up safe. And then governance. Good governance is the bedrock of any efficient, effective organisation. So we will always have a strong governance section, and it will cover all the different domains of governance when we need them to. Clinical, corporate, financial, information, cyber, climate, all aspects of governance will come into that domain. And today we're taking a particular report on the perinatal committee. So this is an update, 2 parts. We are looking at the ways in which we are bringing the improvement plan together, following our acceptance of all the recommendations from the independent review into maternity and neonatal services. We received the report at the 15th of July special board meeting, and we are now finalising the improvement plan to come back to the board for formal approval in November. But we've made significant progress, and we were already on that improvement path before we took the report's recommendations in July, and that's accelerated through the setting up of our own perinatal committee. So we have a significant agenda ahead of us today. And please, if anybody's not clear on any aspects of the board papers, just ask and we'll try and be as clear as we possibly can be. So I'll turn to the agenda now. And then apologies, we have apologies from Matt John. Do we have Deirdre Yes? No, we are due to do she might. So we are expecting Deirdre Roberts, who's going to come to cover for Matt. Liz Ricks is on holiday, and Leslie Jenkins. We have Leslie with us here, and then Nuria has actually apologised as well. And just to introduce and welcome Teresa. Board members will know that Teresa has joined us as an aspiring board member under the Welsh Government programme for the next year. Very welcome, Teresa. And again, if anything's not clear, if you want clarification on anything, please ask. Okay, thank you very much. So can I turn to declarations of interest then, please? Nicola?
Decline interest in item 1.4, please.
Thank you. So Nicola, you're very welcome to make any contribution you want, but if you could leave us when the board makes a decision.
Yeah, of course.
Thank you. So at that point then, I will turn to 1.4 and 2.4 Simon Hospital and Leckie. I return to you, please, to begin.
And so the purpose of the report is to provide a comprehensive update in respect of the position at Simon West Ward. As the chair has briefed, there have been a number of patient and staff concerns that we've been unable to mitigate despite current mitigation efforts. Approval was sought at special board on the 11th of September in respect of planning for a phased temporary movement of the ward to Singleton Hospital Ward 3. So the purpose of this paper, and we're seeking board approval for the temporary transfer of the ward across to Ward 3. Just as some background, since the special board, we've deployed one of our social nurse directors to work closely with the service group and with Singleton Service Group, particularly in respect of listening to the staff and engaging with the staff, particularly in respect of staffing for the transfer. So you might have some questions in respect of that. But the paper is comprehensive. I'll take it as read and I'm happy to take questions.
Thank you, Leslie. That's really helpful. Richard, I'm going to turn to you next, if I may, as a clinical member of the board, to give the board your advice, and I'm then going to turn to Rodri. Richard.
Very much, Ms. Chair. As a board, our primary concern is the safety of our patients. And what has emerged in Gorsinon is a situation because of deficits in staffing and isolation of that unit. Is a situation where, despite multiple attempts at mitigating those risks, we haven't been able to. And the concerns that have come through clearly pose a question about whether we can safely provide that service in that location. I was struck in particular by the fact that we have 50% of our staffing there on occasions is with temporary staffing. And we know that when that happens, it's difficulty maintaining a cohesive team. It's difficult having people who come in on a temporary basis who aren't familiar with the environment. And much as their skills are appreciated, what that doesn't do for us is provide a holistic service to give the quality and safety of care that's required. So what we described as the solution in terms of looking to temporarily move people with patients to Singleton Hospital mitigates a lot of those risks. And I'm sure Rodri will want to comment on that, both in terms of being on a site where backup, should and when it be necessary, is more readily available, and a location in which we can strengthen the leadership of that team and support that team in delivering the best possible care. Obviously, I'll send Lucas.
Thank you, Richard. Rodri, Professor Mauretto, very warm welcome again. Over to you.
I think just to reiterate some of the points that Richard's brought up really is, I think there are two things really. One, the risk that we need to address, and one is the crisis in terms of staffing with the lack of permanent staff there, and that's running at 50% for some of the nursing staff, and that has real problems in terms of building a team. I think the second thing is about the population there and safely managing them, particularly with the out of hours cover, and the fact that Gorsinon is an isolated unit, I think is a significant risk. And I think, as the health board has seen our rehabilitation services change with time, isn't it? And so the population that are having inpatient rehabilitation is very different to how it was maybe 10 years ago. So lots more patients are having their rehabilitation at home, and the patients that are having inpatient rehabilitation tend to be much more vulnerable and at risk of fluctuations in their condition. And I think having cover around the clock to be able to support those patients is really important. And because of Gorsinon's location in isolation, that isn't possible, and we rely on those patients being transferred back to Morriston if there are problems, medical problems out of hours. Whereas in Singleton, we have a medical team on call to cover the oncology teams, to cover the maternity teams there. So there's a medical registrar there around the clock. And given that we've got space in Singleton, I think it makes sense on the temporary basis while we look at it that they have the benefit of that cover out of hours really. So I think for those reasons, I think it makes sense in providing safe care for that group of patients.
I'll open it up then, please, for Nicola. Thank you.
Thank you, Chair. Just thank you for allowing me the opportunity to speak today, especially with being the local councillor representing Gorsinon and also a resident. There are some huge concerns from the community. Nearly 2,000 people have signed a petition to save the hospital. The history of the site is Rufus Lewis himself donated the hospital to the residents of Gorsinon. So I think some major concerns, is about the longevity of the hospital from the community. So we're just asking, they are asking if we can just please confirm that, the temporary measures are only temporary, and we are going to give a commitment to not be closing the hospital. And just one other thing they have asked as well is whether it would be possible to maybe do some outreach work with the community when they are potentially looking at shaping any future services there, maybe a health hub and expanding outpatients capacity, etc.
Thank you, Nicola. I'm just going to ask Gabby to respond to that point about closing the hospital before I bring in Jean then. Abby?
Yeah, that's really helpful, Nicola, and we've heard that loud and clear from local politicians and from the community. The inpatient ward is one aspect of the hospital. It does many services for the local community. And interesting, the ward actually is one of the bits which isn't specifically for the local community because it is the subacute care for that part of our patch. And the equivalent on the other side is in the Port Talbot Hospital, which plays into Roderick's point about it's a different model there. In the Port Talbot, it's clearly got all of those other range of services and more inpatient provision. So in terms of it being a vibrant hospital hub, might not have inpatient beds in the short term while we work through what the longer term solution is. But in terms of providing a health hub for the local population, we really want to work with the local population about what the right solution is in the longer term, because this is we have to take this decision because of the immediate pressing safety concerns. But we need to take our time then, reflecting on what the clinicians are telling us about the model of care, and looking at what would we do to continue to develop that as a hub. So our commitment is it will continue to provide a very important provision of community-based care for that locality, and we want to work with the local community and primary care providers about how we can build that up.
Thank you. So I've got Jean, Rena, then Richard. Jean.
Thank you, Jan. I think the report highlights a comprehensive look at how we're managing the quality and safety of the patients. My concern is around the staffing arrangements too. So in the transition plan, what I'd like to take comfort from is that we've prepared the staff who are receiving at Singleton, not just those who are transferring from Gorseinon, but also the ones working in Singleton and having to embrace the patients coming over. So what I'd like to take as some comfort from is that we have done that preparation in Singleton in terms of accepting those transition plans.
Leslie, do you want to come in on that one, please?
Yes, thank you. So there's been a significant piece of work in terms of preparing substantive staff for the transfer. Currently, we have a very experienced ward manager and a matron deployed to support assignments. So we've got that interface to support the transition. The staff that are being asked to staff substantively will be experienced. Ward 3 was previously an elderly care ward. So the key here is gaining a complement of substantive staff. So that was one of the risks around the temporary position. So that work is ongoing and the engagement is ongoing with the assignment staff as well as the Singleton staff. So that staffing model is currently being prepared in terms of receipt of those patients.
And Jean, we have asked that the full transition plan is sent round to the board for information, and that we will make sure that happens following today. Rena, please come in.
Yeah, I was particularly worried about the staffing issue too, in that we appear to have got ourselves into a position where up to 50%, as Rich has mentioned, of staff were temporary or agency or whatever. And that does worry me that we've actually, feel like that has happened in an area where it is quite vulnerable, as Rodri has said, in terms of that clinical presence. So I just really want to know that in terms of the arrangements proposed in Singleton, are we confident that we're not going to end up with this 50% again, and that the arrangements in Singleton are sufficiently robust to allow us to cover the clinical deficit that Rodri was talking about?
I think, yeah.
That's a key issue for us in terms of risk mitigation. I think the difference with bringing an isolated ward into a main hospital facility is we can draw upon internal resources, and that's a key difference in terms of using substantive staff to mitigate any unplanned shortfalls. So I think that would be a significant measure to strengthen the substantive staffing so that we eradicate the reliance on temporary staff.
And one of the things we will be doing, Rena, subject to the board's decision, is remitting to board committee oversight of the whole staffing agenda. So, Richard?
Yeah, I just wanted to come back to Nicola's point and to build on what Abby, Chief Exec, said as well. All the conversations we've had is about a vibrant future in terms of Gorseinon Hospital, and obviously this is a conversation about one part of that. There are a whole range of other services there. the context for the discussions about the future will be the clinical services plan as well, and the engagement we do around that. And coming back to your question about a commitment in terms of Gorseinon community, we will hold an event within the Gorseinon community where there will be that opportunity then to feed into what the wider plan is across the health board, but particularly obviously in relation to the role that Gorseinon plays going forwards, and it being a bright and a vibrant role as well.
Thank you.
So I've now got Andrew, Tina, then Martin. Andrew.
Yeah, no, I just wanted to add my comments as also a Gorseinon resident whose grandfather had to give a day's work free to Mr. Rufus Lewis in order to establish the hospital and maintain it. I'm clearly keen to see that that facility is maintained, but obviously having seen all the detail of the report, I can see that the staffing issues are of considerable note, and we need to do something about it. And the reflection of the balance of what we've got to do, clearly patient safety has to be the main concern. I was also, in a sense, heartened by the fact that looking at the data, we can see that it's not particularly for the residents of Gorseinon, it's for the whole of the population, and therefore the service is not drastically changing for the population in that sense. But I'm also, in that light, I'm also keen to see that there's a vibrant future for the hospital. I'm sure as we take us through the committees, we'll be making sure that that does happen.
Thank you, Andrew. And we can give that commitment in terms of the future. And as we said, working with the community to see how we can optimise that. That's Tina, please come in.
Yeah, thank you. Just to confirm that I will be undertaking a review into the staffing and cultural issues at Gorseinon, and we have already started introducing an early warning system. So it's a heat map available that looks at a range of soft and hard workforce metrics so that we get early indication if we've got teams in distress, either from a cultural staffing perspective, and that will be included in my review. Jan, I'll be bringing back recommendations through the Workforce and OD committee on that.
Thank you, Tina. That's really helpful. Thank you. Martin, please come in.
Yeah, thanks very much. I just want to make a comment and observation, I suppose, in the efforts that I think the senior management has played in all of this, really within the health board, in facilitating from a staff side perspective and generating that sort of comment from members of staff at Gorseinon, really, because that is very important from a continuity, and bringing in sort of the issues around culture would make a big difference really in going forward in strengthening that team. It's just nothing worse than, and I can see that the positivity of getting the people that, the patients in that area now into a more substantive place, which is more functional from a clinical perspective, is far important and outweighs, I think, any other sort of discussions that we have had. I think it's important to note as well, really, that the discussion that we've had with staff side and in partnership really has worked well in engaging staff there in that transition, because there's nothing worse from a staff perspective in knowing something is going on. I'm being moved from my place of work, and where do I go? And it's the fear of the unknown. So thanks, Leslie and Liz for that sort of, and Tina as well for her team to sort of working with staff as well. I think it's important to note as well, really, that I do get in Italy that from a staffing perspective and the agencies that we've got coming in through the door, really, there's nothing worse than turning up on that day if you're the manager and the ward manager in charge, when you've got well over 50% of your staff from an agent that don't know those patients. So from a patient safety perspective, that continuity of care is greatly important, I think, in the clinical context. And from a staff perspective, is about continuity, knowing how that function is the better patient care really at the end of the day. But thanks for engaging with staff and partnership.
Thank you, Martin. That's an important point, really. I've got Steve, then Teresa. Steve.
Yeah, thank you. So I've got a question for Leslie, but just on the future Gorseinon issue. In my view, as we move more services from acute settings into the community, we're going to need more hubs like Gorseinon, not fewer. So I would think that one is very soon. But the question I had is, in your paper, you indicate that we're moving 30 beds from Gorseinon to Singleton. As we all know, during the last several months, even year, the bed numbers utilised have been much higher than that, unfunded. So is it the case that we will only be moving 30 beds and that there will be no surge capacity in Singleton and that will be managed as a 30-bed operation only?
I'm sure this is a question for the staff as well, that there are physically only 30 beds within the footprint. So in theory, it can only accommodate 30 patients. And also for the elderly as well, that is really important for their experience. So yes, it's a 30-bedded medium physically.
I'm going to ask Deb to add to that.
Yeah, thank you, Chair. So the constraint that we will be working with in totality is the budget. So the budget for Gosainan is set. The bed numbers that have been housed in Gosainan have fluctuated between 30 and 43. Actually, 30 has never been the number in Gosainan. That was done as a calculation of what we could staff with the budget that we've got available. Given that that ward now will be housed within a bigger hospital, there's an opportunity to reconfigure how the patient cohorts are managed. So there'll be opportunity to visit the staffing cohort that goes alongside that. So what we will do, we will work within the budget. That may give us the opportunity, because there is additional resource, additional bed availability in Singleton, not on that ward, that we could fluctuate as well. So the constraint will be the budget. We will work within that budget to make sure that is met, and then we'll maximise the bed availability for us to make sure we meet the needs of the population.
And I'm sure we'll be coming back to that, Deb, as we move through the winter months. So I have Teresa and then Rodri to come back, and then Claire Taylor from Llais. I'll come to you then, Claire, for the Llais view. Teresa, can you come in?
Just to add to what colleagues have already said, I think how we boost staff morale is very important. So how we look after their own well-being as well, but also try to mitigate some of the pressures that would come on them. So that's something we need to consider, and I think that's where visible leadership from the board and line managers will be very important as well. But aside from that, do we have a clear timeline for public engagement? Because that will be very important, and that could potentially reduce some of the pressures we are receiving from the media and from the public, and that would pose a significant gap. But also when it's asked if equality impact assessments have been conducted, just so that we are considering groups that are not necessarily engaged. Or
Richard, would you like to start with that?
Yes, on the last point first, so the impact assessment has been done, and it's within the sort of supporting papers in the board pack. On the engagement, on the timeline in terms of public engagement, I think in terms of the event that I referred to, it makes more sense to hold that in the new year, because that will fit more neatly into the timeline in terms of the clinical services plan. But to be honest, I think the engagement that we've had around this already in terms of individuals feeding in views and contributing, I think that's really important as well. And we get a real sort of sense of feeling for the Simon Hospital in that sense. So I think, we use that in order to get more engagement over the next few months. And we'll do that not just by an event, but also publicity and other means of feeding in as well. So it'll be an important part, not just in relation to the Simon, but also in terms of the wider health plans as well.
The only final comment I would make, Jan, really grateful for the staff for having the courage to speak out and raise the concerns with us. I know we've been working closely to try and resolve some of the issues, but the point of an engagement with Liz and Deb and the team around actually the point where we need to do something different. I think that's really important. And Martin, thank you for your comments in terms of staff engagement. That I think there's always something about when you recognise the need to move into a different phase of the work, and the way that we've engaged with staff and your comments are really helpful, because that is just so important, as well as engaging with the communities. There's always some lessons learned about when you start going public on these things, the sequence, the order of which you engage. And Teresa, your comment around that, about making sure that when we go into those things, we are making sure that there are no unintended consequences that we haven't thought through in terms of different aspects of communities and any issues that we might not have thought through. And that's why the impact assessment process is so helpful to us, because it enables us to systematically think through that, and that's been really helpful to us. So yeah, thank you.
Thank you. Rodri, final comments from you before I turn to Llai.
I just wanted to pick up the importance of Simon as a hub for lots of other things and actually COVID had a big impact on that. So prior to COVID, we had a day hospital there and a rehabilitation gym where we were doing strength and balance classes for the local community, and it was really valid, and there was a care of the elderly clinic every day there, and we changed that into part of the bedded facility actually, and I think there's a massive opportunity to bring that sort of thing back. The other thing that happened in Gorseinon during COVID is that a very successful heart failure service serving the community was set up within the footprint, and that's continuing there. And I think, you know, the Parkinson's service is run out of Gorseinon as well. So there are lots of really important aspects that support the community in Gorseinon that will continue to base. This is the inpatient bit is a very small part of that.
Thank you, Ron. It's really important points, and we will make sure that communications from now on emphasise just how much happened in Gorseinon. Claire, Gordell, would you like to come in?
Good morning, thank you. A few of the points that I would have made have already been discussed. Firstly, there was really just clarification around what active engagement has been made with the patients on the ward and their family members. And then secondly, it's really about timelines and monitoring. So how long are we thinking that this temporary change will be in place, and what is the schedule for it to be monitored and reviewed?
Leslie, do you want to talk about engagement at ward level?
Yes, so we currently have, as I said, an experienced matron and a ward manager and our associate director of nursing deployed in terms of visible leadership of the unit. I think in terms of waiting for the board approval, direct engagement with the families then will become more intense as we work up to the was transferred in on the first, acknowledging that cohort of patients will be changing.
Thank you. And we will give more detail on that, Claire. We'll also send to you the transition plan, as well as sending that round to the board, because that will give you additional information as well. And then the monitoring arrangements, Abby, in terms of just checking how things are going. We're going to remit to ward committee the staffing issues. We're going to remit to quality and safety committee, Jean, the whole patient safety agenda, given that this all started because of staff raising concerns about patient safety. But at the moment, we're working on to the October-March timeline, during which time, Claire, as Abby said earlier, we will be looking at models of care. Want to expand on that?
Yes. So I think, as Richard said, we've got two processes working in parallel. Really, we've got the work that we're doing on the clinical services plan, which is kicking off in earnest, that Marie's leading this in paper later on the agenda. It's really useful timing that at the national level there is work moving on the model for I'm going to get the term wrong because it keeps changing, but what was the primary care model is now moving into integrated community models, and that's accelerating really quickly. That's really helpful timing for us about what do we need to have in terms of shifting appropriately more patient contact closer to people's home, where it doesn't need to be in an acute hospital setting. So that can work very well for us in terms of the timing. And I think there's a national summit that a number of us are going to with the Cabinet Secretary. Is it the 14th of October? I think it's the 14th. Again, we've got a really useful national paper on this. Our clusters are really engaged. I think yesterday our lead GP on the clusters is actually presenting at it, so we're getting in there early with our views, which is helpful. But that will also help shape this. And Claire, we will engage you through the existing forums where we engage with CLICE and involve you in some of the events that take place and activities. So we'll sit down and talk you through that timeline and where you want to engage, and of course advice from you and the CLICE team about how we do that really effectively will be really helpful. Thank you.
Thank you, and thank you, Claire, for your comments. So Nicola left us, and we'll record that Nicola has left us for the decision. So we have 3 recommendations in front of us to acknowledge the safety concerns and the implications if we take no action, despite the attempts and this, the really significant attempts to mitigate and resolve them. They've not proved successful. So also to acknowledge that the planning phase is completed and the proposed plan now to transfer 30 beds from Gorseinon to Singleton, and then to approve on an urgent temporary basis the transfer of the ward to Ward 3 in Singleton with effect from the 1st of October. We content. Thank you very much. And Rodri, thank you very much for your time this morning. You're very welcome to stay with us, but I'm sure you've got hefty clinical.
Thank you very much.
Thank you. Very much. Thank you.
Thank you, Rodri. And also just to express thanks to Emily, who's joined us online. Thank you, Emily. I know you did a lot of the holding the ring in terms of pulling together board papers with colleagues, so thank you so much.
Thank you again from the board, Emily. So I can't see you on my screen, but thank you ever so much for being with us. And as ever, you're welcome to stay if you want to listen and see the rest of the agenda. And Nicola, just to confirm that we did make the approval and that as a member of the board, you will get the full transition plan as well, so you can take it back to you. Thank you. Thank you. So Abby will turn to you now, please, for the Chief Executive's report.
Thank you very much indeed, Chair. Colleagues will be aware I use this report to highlight action that we're taking or issues that we need to escalate or just make you aware of in relation to the overall positioning of the Health Board in respect of Welsh Government and the escalation arrangements and in terms of the key areas of programmes of work that we've got going on in the organisation. So I will just reference a couple, if I may. The escalation framework, we're still waiting for the final version of that. Marie received, I think, was it this week, Marie, or in back in last week, the final check. I had hoped that we would bring that to the board today, but it's not quite there in terms of Welsh Government. And what it does is confirms the escalation status and the expectation on us in terms of the activity that we undertake to improve our position, and really importantly, clarification on the explicit milestones we need to hit for de-escalation. And obviously some of those are quite complicated. We're just working those through. So that is work that is almost there. It will be published on the Welsh Government website. So my expectation is it will be available before our next board meeting, and I will direct Health Board colleagues to it once we get that final version. I'm going to say very little about maternity and neonates because we do have the perinatal committee paper, and I'll bring my comments in at that point on the agenda if I may. But I did want to touch upon mental health services. Colleagues will probably be where we were due to bring a comprehensive report back in terms of options at this meeting. And as part of the engagement process with our staff and teams, we want to continue that engagement for a little bit longer in terms of the options, because another option was suggested and we need to work that through. It's really helpful. That's the whole point of engagement. And we will be bringing that back to the board meeting in November. We're confident in terms of the work that we need to progress. It shouldn't impact on the end timeline, because I know that's all our concern about how quickly we can move. And Melanie Walker is continuing to work with Narissa to provide the support to the service group, and grateful to colleagues that are making progress in terms of the individual work streams. Narissa did bring an update yesterday to the formal executive meeting, and I have to say it was really positive. It was really heartening to hear the progress that's being made across all of the work streams. Dean hasn't been able to join us yet, and that's not here, but the digital piece, Andrew, that you're very aware of, it's extraordinary how quickly the teams have actually been able to make progress. So we do now have some of our more vulnerable teams in terms of things like crisis team and home crisis team are now on our patient administration system. So we have an electronic mechanism for capturing that information. And there is good news coming through in terms of being able to accelerate the digital solution for mental health, which we expect will be the community solution in the medium term. And actually Welsh Government are being very supportive with that. Jan, I would suggest that we share a note round to the board members with the waiting to the next meeting on the progress, because it's really good news. And then the final thing to mention in here, and grateful to the service group for providing a more detailed paper in the annex, to bring to the board's attention that in light of some real challenges with the physical environment in our mother and baby unit in Tonner, we are needing to suspend new admissions and discharge patients appropriately to enable us to do some absolutely critical work to both the roof of the building, that bit of the building, and to the heating. We're not able to get the right heating for babies. Clearly, that's a really important thing in terms of providing the right environment. Colleagues will be aware it was shoehorned into a building that wasn't fit for purpose in the first place. So we recognise those challenges. We've been working with JCC. The staff will continue to support the cohort of patients even if they're being cared for in an inpatient place in England. And of course, they will up the outreach work. Colleagues will be aware, before we introduced it, there was no service in Wales for a period. So the teams that we've got will continue to work. They're very much engaged, the team. As I said, down the estates and capital team done a great job in terms of supporting so really grateful for that. JCC actually being very supportive in terms of recognising this is something we absolutely have to do, and there's no good time, but trying to get that done this side of the hard bit of the winter is really important for us as well. The only final thing, Jan, two things, if I may. I've just put a paragraph in about the strategic estates plan because it plays into, Jan, what you said at the beginning around strategic direction of travel. And we know that we are not sustainable from a financial point of view in terms of the way that we're currently distributing our services and delivering our services. We have a plan for this year, but we've always talked about service reconfiguration, looking at how we deliver our service, and the way that we deliver our services is we have to move faster at that in terms of our agenda. And strategic capital to enable us to do that is really important. We know it's really challenging in Welsh Government because there is a lack of capital to do all the things, and therefore prioritisation is really important. But I just wanted to flag a really key milestone in terms of the key enabler for the road access to Morriston is coming up. I'm really, again, grateful to Darren's team for holding the ring on that and the positive discussions that are happening with Welsh Government in that regard. And then just the final thing, if I may, Chair, just a very brief paragraph on our Organising for Success programme. Tina's the SRO for that, really grateful for that. We're putting some more support around enabling that to happen. It's really critical that we are organised and structured in the right way to deliver on the very significant agenda that we've got. And we are looking at how we might accelerate some of the components of that in a more timely way. And we're just working that through at the moment. And again, I know Workforce Committee will provide some oversight for that because it's a lot of that's about how we're organising our people. So Tina working with Hazel both on the governance side of that and the workforce side of that, and we'll keep all members informed when there are key milestones that we need to bring to your attention. Thank you, Chair. Happy to take any questions.
Thank you, Abby. And that does cover a lot of ground and set the context so much of the coming months and into the 3-year trajectory with which we are working. So any questions or comments for Abby, please?
Thank you, Chair. Delighted to see that we are doing the works that's obviously urgently needed in Tonna. My question is really just about what support we are giving these families, especially if they are having to now go to England. It's not just the mum and the baby, it's the families, etc.
Yeah. So that'll be part of the conversation with JCC about how we support people. So clearly it's about making sure if there's an alternative to an admission, we're supporting that. And again, having the team locally available, there'll be some admissions that we might be able to do something different with in terms of avoiding admissions, but working with JCC to make sure the admission is for as short a time as possible. Because, you know, we've visited quite often and that is a really big issue for families, and you know, travel is really expensive. So if your loved one and your baby is somewhere far away, we acknowledge the difficulty. So making that the works as quick as we can to keep it as a very minimum, and hopefully it will just be a very small number of absolutely critical, unavoidable admissions that have to happen into England. And JCC will support families, so there's a mechanism of enabling support. And of course, we'll need to keep in contact with those families because they may need to transfer back to us when the unit is able to take admissions again. So we'll be keeping very close touch around how the referrals come through and our interface with any provider that may need to step in to provide an inpatient admission. But really important. Thank you, Nicola.
Any other comments for Martin?
Just to pick up on the reduction of babies, mother babies coming into the units, really. Is there a workforce plan in support of the staff that are currently residing, working within the unit as well? So I'm just sort of querying whether the workforce level is not going to be reduced, we're going to maintain what we've got.
Yeah. Darren, please come in.
It was just on the capital point, Chair, if I may. What we've submitted now is a full planning application for the access route to Morriston. That's currently with City County Council, City and County of Swansea Local Authority. We anticipate that arriving at the Planning Committee in either October or November. And clearly we've engaged with local populations prior to that. So it's a very exciting thing for us, very visible to our local community. And we've had quite good engagement on that as well, a lot of support. So I'll be pleased to bring that back to the board when it's available, and we've got Capital Today's task force on Monday where we'll explore some of that detail.
Nicola, relevant to your other role as well.
You're right. Thank you.
Okay, thank you very much. So we can consider and take a short. Oh, please, want to come in?
Thank you. Just to follow up on Darren's point, obviously the planning for the road, the funding for the planning for the road application that came to Swansea Bay City Deal, and I'm very grateful to the Health Board for their the work they've done on that, and look forward to collaborating further through the university with that on future developments.
So we take assurance on Abby's report then, and move to our staff story. And it is really important that the board has line of sight down to the front line, so that we understand exactly what it's like at that front line. And today we have a staff story around T. Olwen. And Leslie, and you again?
So we've chosen a patient stories, it's the palliative care story, and this is in line with a recent visit to the unit. So I would suggest we listen to the story, and if there's any reflections that you'd like to discuss.
My name is Suzanne. I was diagnosed with bowel cancer 5 years ago at Morrison Hospital. I came in as a patient with stomach pains, no symptoms, and ended up having emergency surgery where they found a tumour, treatment, not chemotherapy at home. It was always looked at a curable. Last operation I had, it came out that I was no longer curable, it was just treatable. So I've been having chemotherapy at home, which has worked really, really well for me and my family. On a recent treatment break, I just really started to suffer with horrendous pain. The palliative pain team from Powys have been able to support me, which was arranged through the GP service. That was a bit scary in itself, hearing that word palliative. And as I've been told, you know, my condition was treatable. Came out and we tried lots of different options to manage my pain. Some worked, then we were back to square one, until I actually hit a brick wall. I was asked would I come into T. Olwen. It was very scary because the perception of T. Olwen can be end-of-life palliative care. Having been here, seen the remarkable work that the whole team do, you know, areas of knowledge and the skills that they've got just to help me and alleviate the pain has been absolutely amazing. It's not a place that people think it is. T. Olwen's got so much to offer rather than end-of-life care. I'm now walking about, I'm pain-free in the evenings. There are procedures done that maybe would have taken weeks to facilitate elsewhere. And what it's going to allow me to do now is to have my radiotherapy. I think all the staff have played a part. The nurses are so well trained and they understand a bit of the cancer journey. You know, the umbrella and the word palliative covers so much. You know, I'm on the bottom steps. That's what I feel, on the bottom of the ladder. I'm just popped in for a little bit of pain relief and I'm going to pop back out. And I just feel if something gets a bit difficult now, I can pop back in. And this would be the best place to come rather than a ward, because the staff's knowledge, understanding, their skill sets, what they can do, what they can offer is absolutely amazing. My family can visit, it's like home from home, with that beautiful sunroom where we can sit. It's been lovely to see the family room for family members who do want to stay the evening with the patient, but just covers everything, not just the end of life. And I think that is the one thing I've taken away from my stay in T. Olwen. It's opened up a few things personally, and my son was offered a month off work because I was in T. Olwen, which was absolutely fabulous of his employers. You know, how they were trying to support him, but once the word T. Olwen was mentioned, they tried to tell him that he didn't know how ill I was. But thankfully, a lovely nurse, I happened to speak to her, and we had a lovely lady that happened to walk in, and my husband's been able to talk to her on a one-to-one basis as a sort of counselling programme, which we didn't realise maybe that he needed. It's just really, really helped having, you know, been called into a meeting, told your mother's really ill, and start being told on T. Olwen is people end life for. There's a lot of barriers to pull down around that, really. It's a beautiful building that was built 40 odd years ago, But what it was designed for has totally changed. It's now obviously spreading its wings and helping anyone that needs that extra, care. With the pain team here, we're able to address it, so we're monitoring it as nurses and staff. It's only by coming here that's facilitated, and so that's going to happen. Having the support and the encouragement here, feeling that pain go away. I didn't realise how much pain I was in, and I've just had good news. I'm going to start my radiotherapy tomorrow. I would never ever be afraid to come back to TR1. I definitely think it's a bit of work that we need to do to have others understand it is not the end of life. This is a place you can come and have quality care, quality treatment, and enhance your life.
So it's a very emotional story, and I think in the face of a difficult diagnosis, it's a heartwarming quality story in terms of the lady being able to fulfill life in a pain-free way, and also interesting around her perceptions around Tywyn and what Tywyn offers, and has put a different positive light on that. So I found that very emotional. So I don't know if there's any reflections from colleagues.
Two reflections really. One is around people understanding what palliative means in the broader context. And the second one is the power of communication. So when we're talking about the places to which people go for whatever treatment they want, I think it's important that we think in our communication out to patients, out to the population in general, that we can share those kind of stories and experiences to build that external knowledge of what the places that we offer really have to offer. So there's an opportunity there, I think, for us in understanding how we can help people better understand their facilities that we have to offer them. Steve.
Yeah, sorry, thank you, Chair. So I also visited Tywyn recently, and it's a great facility, but I think people should understand that it's the tip of the iceberg. What happens there? We've got 12 going on 14 beds in Tywyn at any one time. But when I visited, the consultant, the palliative care consultant, told us she had 50 patients in the main site at Morriston, possibly about 25 in the Talbot Hospital and 500 or so in the community. So palliative care that team is providing is much bigger than that small unit in Tywyn. And it's a great service that's done. And the more it's done in the community, i.e. in the care homes or in actual homes, the better.
It's a really important point. I've got Martin, then Richard.
Thanks, Leslie. I think patient story is one of the most powerful things I believe that we can sit and listen to, really, especially in the delivery of healthcare. And I sort of, patient story for me is the best medicine, I think, as a service that we can have. That we are getting things right for the people, for the patients. And it's also a good dose of medicine in these hard times that we're seeing, within the health board. But from a staff perspective, they're getting the service, the quality is going through, is there. And I think that is a good sort of outcomes, even great for the patient, don't get me wrong. But from a staff's perspective as well, really, it's nothing better than going away from having worked and delivered care to a patient and getting that positivity from that patient. For the staff to say, well, yeah, today I've done a good job. And I think for me, that it's synonymous. It's just really good to sort of see the outcomes for the patient, but for the staff as well, really. And I think all of that maybe need to share, really, because we're delivering the services that we want to deliver the best way possible.
Thank you, Martin. And as we get the broad walk around programme really underway, obviously we'll be out and about more in the service to experience that. Richard, please come in.
Yeah, I'd just like to draw some of those comments together, actually, because I think they're really powerful. The impact on the individuals, the impact on their families, the impact on staff as well, and the positive sort of reflection on the commitment and motivation of our staff to make a difference as well. But I think what we can do over the next probably 12 months or so is look at different areas like Tywyn and reflect that back to the local population in terms of better explain, shine a spotlight on what actually happens there. And I think staff will benefit from that, the patients will, and their relatives will as well. So I think that that's a really helpful conversation, and we'll take that away.
I'll give you an action point on that.
Yeah.
Teresa.
Yeah, I was just going to say it was very, heartwarming and just reassuring that, the work the staff do kind of resonates with people. And it's nice to know that people's lives can actually be improved regardless of the diagnosis they get, or especially in that specific scenarios. And just like colleagues have said, it's important that we're sharing these stories externally as well. And I think there is an education piece here and an outreach opportunity here to be done, especially with communities where such type of diagnosis could land differently for them. So knowing that their lives can be improved through the services that we offer, regardless of where that is.
I wish you can make use of those comments, Teresa, when picking up the communication. So Leslie, can we ask you to thank Suzanne for sharing her story with us, and obviously convey our thanks again to the staff of Tyrwyn. Nicola and I have been several times recently, and it's very moving. Nicola.
Yeah, I think it's touching as well on the importance that the charity do there, so I think it really showed the health board and partners working together at its best. And I think we need to be showcasing that as much as we can.
Yes, and Abby and I shall just go meet the trustee in the coming months as well. So that's great. Thank you. So let's move on then, if we can, to part 3, which is our future focus and setting strategic direction. And we always have a population lens, and Steve, you're going to take us through the report from the committee.
Yeah, thank you very much, Chair. And so you've got the AAA report there. There are 2 alerts to bring to your attention. The first is regarding cancer mortality. We received a presentation from a gentleman called Duffield Hughes, who's Director of Welsh Cancer Intelligence and Surveillance. And the committee were very, impressed is the wrong word. It was actually quite a challenging presentation in terms of the level of mortality and the variations in mortality across different areas within Wales, but also within Swansea Bay. You'll recall that we had a screening paper from the last paper, which showed that the take-up of bowel cancer screening in Swansea Bay was the lowest in Wales. It's about 65% against a Welsh average of 66, but some health boards are doing better than that. Bowel and lung are the 2 biggest killers that we have in cancer in Wales. But that 65% itself doesn't paint the whole picture, because 72% take up from the least deprived areas, and only 59–60% take up from the most deprived areas. So there's a huge differential there. And there are other differentials in terms of getting cancer. The contributory factors include age, they include ethnicity, they include deprivation, obviously. They include your household tenure, whether you're an owner or a renter. They include overcrowding. If you've got a spare bedroom, you're less likely to get cancer than if you haven't. And quite clearly, living where we do in the very challenging circumstances that some of our communities live in, cancer is a serious threat. And as I've said, we're not very good at getting screened, because it was noticeable that within Swansea Bay, many of the patients that come to the cancer services are already in stage 3 or 4, where it's often either too late or very late to get proper treatment. So I would stop at that point and invite questions on that issue. Well, I'll move on to second alert.
Yeah, I was just going to say that this paper came to the stakeholder reference group, and there were several of the members of that group, the stakeholders, who felt that there were maybe ways that we could help to strengthen the screening process and get that message out and contact people.
Yeah, and I'm sure Jill will pick you up on that. But I will come back to you in a minute, Jill, when to take the question. Rena.
Yeah, unfortunately, I didn't make that committee, but I certainly did read the paper and I did feel there's some really key things in that for us in terms of our population health agenda going forward. And in a sense, what I'm quite keen to find out is what are we going to do about it in terms of resolving some of these inequality issues that we know exist in our population. And across the patch, particularly in terms of cancer, but it also relates to other areas.
Thank you, Rena. I'll ask Richard to come in there.
Thank you very much. Thanks, Rena. Yeah, I think it's a really interesting question. The other part of it is at the point we're screening and trying to find the people, what we're doing is trying to find people who've got cancer. Actually, we prefer to be further upstream, actually preventing those cancers so that there are fewer people who are screening and testing positive. And on that aspect of it, you know, if you look at one, I'm talking for us, Jill's patch, Jill might want to find, in terms of the modifiable factors for that affect health, only about 20% relate to health. And so, we will know that in those other areas of our communities where there's deprivation, that there'll be other factors associated with that, as Steve's alluded to, in terms of housing, employment, environment, all of which also have an impact on and increase your likelihood of getting conditions like cancer. So I suppose the part that we do, which is the screening, is the part of our population health and encouraging healthier choices, healthier lifestyles. It's also how we work with government across these other areas and address those other inequalities, which aren't necessarily under our remit, but will certainly impact on us directly and on patients' on patient disease harm and their survival.
Yeah, do come in.
So yes, a lot of those sort of measures that we were talked about at the Population Health Committee, they're actually proxies for deprivation. Right? If you've got 1 or 2 spare rooms, you're living in a relatively, large house, and you've got, more room than you need, and overcrowding, you actually have less room than you need. So, so some of them are proxy measures. But Richard's right, we do need to look at primary prevention. So smoking cessation is absolutely key, our community and our own services. Also reducing alcohol misuse, so working with the area planning board, what we're using later on, thinking about what we can do in terms of brief intervention when we do have people who are acutely ill. Also our weight management and our encouragement to the public, health literacy on healthy diets, high fibre diets, the less animal fats, more diet, fresh fruits and vegetables. Also working with industry, so we work with industry on environmental hazards and occupational hazards. And earlier diagnosis is key. So working with communities and with practitioners, health professionals, to encourage people with red flag signs to come in, see their health professional, the health professional working with them so that they understand, in the midst of a very busy practice in the area, what are the red flag signs that they really have to have a high index of suspicion and refer. And then also encouraging prompt referral, prompt access to diagnostics and prompt treatment. So there's a whole host, it's a whole chain, isn't it, that we're talking about. And certainly having the evidence, which we requested actually, they did some analysis on staging of cancer diagnosis because they don't routinely publish that. But David has produced this for us. It may well be worth us sharing the paper so that people can see it, because you won't be able to read everything that they told us in their report. But we do not want that. We want people referring at stage 1. If they have cancer, obviously there's a load of factors we can't influence that happen to them when they're children, that their lifestyle choices through their lives, that cancer sort of genetic mutation might have happened already. But as well as the screening, we need for, you know, us to really be able to recognise that early when they actually do have cancer. So we need to work with them and get our stage 1, stage 2 should be a, oh my goodness, somebody came at stage 2, you know, not a stage 4. Oh, that's not acceptable. But it's not just us. You know, it is, you know, throughout Wales. But our performance is not good enough compared to international standards.
And Marie, can I ask you, in terms of the 26-27 planning round, and clearly as well as one of our strategic objectives, in terms of the reduction of health inequalities, how will we be taking all the data and the evidence that we now have, as Jill and Steve have outlined, and reflecting that in the plan? Because we are required, aren't we, to shift left, more focus on prevention. How do you see that playing out in that?
I think there are a number of arenas where we're looking at that, which I think is positive. I think we do need to take some, there is a note of caution there, however. So from a resourcing point of view, this board is acutely aware that we are significantly overcommitted, and we know that that is a primary responsibility of the board to look at how we address that. So that is constraining what we can do in terms of shifting resources left, because first of all on resources at the moment is bridging that financial gap. Notwithstanding, there are areas of work that we are collaborating on within the health board, so between primary and secondary care, looking at how we can reduce the duplication on a vertical basis. So the community services review, looking at what we've got out there that we can rationalise, reorganise, and that's between primary and secondary care, but also with our PB colleagues. So there are opportunities to look at how we can work collaboratively to look at how we can work more effectively and optimise our resources in the community, and that will feature prominently in the plan. In terms of more collaborative working around prevention and wellness promotion, if you like, so the APB and the PUSH and the PSB arenas are where we are taking those opportunities to share intelligence, join up some of that more strategic level thinking, and trying to translate that into some priority setting, shared priority setting, which gives us the opportunity to have the biggest influence. And that's around things like access to food, early years in particular. So those are kind of those two areas where we are trying to work, where we can influence some of those other modifiable behaviours in the community that are outside of our direct control, but more in the control of our partners.
Did you want to come back before I bring Rena in?
Yeah,
Thank you. And of course, we've got various mechanisms in terms of cancer across the organisation. So Marie's right. There's and building on Jill's point, there's the primary prevention about the wider health and well-being, healthy lifestyle choices, recognising the inequalities there and what we can do, as Marie's just described. There's the kind of secondary prevention, and screening will be part of that in terms of identification. And I was reflecting, Jan, on the visit we did to this cancer rehabilitation work, which is getting people who've been identified as having cancer as fit as possible so that their outcome is as good as it can be. And one of the conversations Richard and I touched upon very briefly yesterday is something we might want to do as part of the plan next year. We in light of our position, there's something about where we're going to get biggest return on, where we prioritise and focus.
Yeah.
And I do think we need to do a very detailed piece of work and probably use Public Health Wales and the National Cancer Network on, for our population, where is the greatest harm? Is there something really obvious? Is it breast? Is it lung? Is it colorectal? And is it something else? I know we've got to go on the cancer access times to make sure people are coming through in a timely way. I'm wondering whether we need to look at where is the greatest harm in terms of gap, and could we do something in a very focused way, not trying to do everything, but to say, let's for example, if it is colorectal, and I don't know what it is for our population, we need to understand that. Well, let's look at the FET test screening. Let's look at the pathways through, and really make sure that in terms of our timely access, we are making sure that every step we are shortening right across the pathway. So from the preventative piece right through to how we're making those pathways as one-stop shop as possible. So you come in and you're straight through, and that we reduce perhaps some of the steps along our pathway. Now, that's speaking without having had much of a conversation about it, but we did touch upon that yesterday and how we get into that for the plan for next year.
Yeah.
Bring Rena in, then I'm sure Darren will talk to us about best investments.
I think something links to what Abby's just said, because I think in a sense, knowing that this is in generalities, not just cancer, that we know we've got major inequalities across our patch. Should we not, in our plans, be thinking more strategically how we can address them and having more focused work on certain areas of our patch where we know they exist? And I just would like to see that coming through in our plans, that we are attempting to address it, albeit that I accept what Richard said and what obviously Gail said in terms of the broader piece in terms of working with the PSBs and with others on that. But I certainly think there is a need to look at it from that sort of focus.
Thank you. Darren?
Yeah, thanks, Chair. You teed up at the start, we're working in the time frames, and we have to address the challenges in all of them, I think. So whilst we've got a very present financial challenge, if we don't lift our head and look to the future, we'll continue to have the same financial challenges year after year. So I think we will hear later about our diligent work on the existing operating model and the cost of that and getting that to a better place. Actually, through things like our value-based healthcare teams, our regional work on allocated efficiency, we've got some expertise coming in to help us in that regional space and some techniques that will allow us to, across some of these really big areas like obesity, frailty, maybe respiratory diabetes, I'm sure we'll discuss in a moment, to move the money within a 3-year or strategic context, which is showing we're improving our financial performance. But we can't do either of those in isolation. We must do them together. We must start now. Okay, from a finance perspective, we work very closely with the short-term and longer-term planning aspects to make sure we do that and on some of these really important things to make the future brighter.
Yeah, thank you, Dan. That's a good idea, a good example of how we cross over the timelines. Yeah. So we've got Chris, then Jean. Chris.
Yeah, it's just to comment on Rena and Abby's comment discussions really. In terms of the cancer prehab, we were looking at the area of most need, which is why we started in colorectal, because we had a small resource to do that, and there was a good evidence to show that you can improve in that area. But we're also looking at, in terms of the Women's Health Hub, we are looking at work to universally improve our pathways. But specifically, if we're going to have a hub and spoke model, we are looking more at where, and through the work that we're doing with co-production, around where our underserved populations are and the areas that we're not reaching now. So that's exactly what we are doing, is we're focusing on where there is no contraceptive advice in clusters. I'm meeting with the cluster this afternoon around some of this to look at the best areas to focus, rather than setting up hubs and spokes in an area which might serve our best served areas. We are looking at what's underserved. Your mama will tell you that actually universal is the best. So that's what we're looking at our pathways, but actually we are focusing on the areas we need to reach. So we're doing that right now.
We've got Jean and Richard, then I'm going to ask Abby to sum up this part before Steve, we move on to the next.
It was, thank you, Chair. It was an observation really that conversation we've just had illustrates what board has been saying for a number of months now, that we have to be better in prioritising the business intelligence that we have. And if we think back to a number of meetings ago, when Deb, I'm sorry to highlight you, but you utilised that effort versus efficiency diagram within one of your service areas. I think the better we can use that business intelligence, be more analytical, and the more efficient we become as we move through.
Eugene, that's an important point. Richard, please come in.
Thank you. Yeah, my comment maybe ties in, Jean, what you were saying to also broaden the prioritisation of the timelines, which is we know for other conditions, so stroke is a good example. Let me start again. In terms of how you allocate resource and what does that free up? Secondary prevention is often quite effective. So if you address high blood pressure and atrial fibrillation, will reduce the incidence of stroke. But actually, for some conditions, and those two that I've highlighted are good ones, you see that benefit start to come through in about 18 months' time. So whereas sometimes we struggle with that timeline of what comes out in 10 years, Jill's point about if your genes are turned when you're a child, it's going to take a long time for us to get to that point. But actually, there's stuff that we can do now that will have a benefit in a shorter time frame. So I think it's how we incorporate into that plan. some of those issues around what decisions can we make now to intervene, what things that we know will have a benefit within the current 3-year cycle, as well as, and we've had this conversation before, that things that we need to start now to get the benefit even further down the line. But actually the primary effort needs to be at what can we get out of this cycle.
Thank you. Abby, do you want to conclude this section, please?
Yeah, thank you very much, and a really good discussion, and it reflects, as Dan alluded to, those conversations we've had about the 3 time horizons we're working in. Some things we can do really quickly. We had a conversation about how do we make sure people are coming through for their screening and that we're able to act quickly on their screening. That's stuff we need to do in year and make progress around that. And some of this is longer term in terms of shaping the dials. But in response to really your comment, Jill introducing the concept of the core 20+5, and Jill, I was just bringing up the paper you shared and exactly really helpful in terms of where we focus, and it's really helpful in terms of where's the evidence. We don't need to go and find the evidence is there. What I'm sure is that we're able to articulate in our plan for the next few years where do we need to prioritise to get best and maximum effect, and for me that is our population health plan in action as part of our wider planning and delivery system. So for me, it's about how we make sure we keep that as a sort of our North Star for the population health strategy as part of our overarching strategy. And I also think, we have committed to metrics in the overarching strategy. We've not done that before. We may not get there, but actually setting ourselves an ambition about how much progress and change we expect to see over that sort of 10-year time horizon we're working will help us keep a sharp focus on this. So really helpful. Thank you.
Thank you. And Marie, I'm sure you'll pick up on this conversation as you look into bring the plan together. Steve, do you want to take us on to the diabetes prevention programme then?
This one may be a bit quicker. We received a report on the All Wales Diabetes Prevention Programme as deployed in Swansea Bay. All of the 8 clusters have deployed it. It is, we believe, extremely effective, and that will be proved, we hope, by a Public Health Wales report, which has been written on the effectiveness of the All Wales programme, which is currently with Welsh Government, but should be published soon. Assuming that report accepts the effectiveness that we believe it has, we would like to carry this forward in Swansea Bay into the next year and thereafter. And that's where the alert comes from. 3 of the clusters are currently funded by the Strategic Population for Public Health Committee, 2 by Public Health Wales, and 3 by us directly. The 2 external sources of funding seem likely to come to an end at the end of this financial year. And so if we want to continue with the programme, we will be on the hook for both our 163,000 and a further 268,000. So the total ask will be £430,000 in the future, subject to inflationary uplifts. And I think the committee will be asking that spend gets incorporated into the plan for next year. Normally at these meetings, I have Darren, the finance director, sitting next to me, and he slips me a metaphorical check under the table. But I don't know if he's going to be able to throw one over at this point.
Aaron, I'm going to hand over to you.
Yeah, thank you. So we'll take this up, Steve. I think it's a real challenge. It's clearly delivering the right benefits, and it plays very much into the conversation we've just had on sort of the broader piece. I've done some research prior to today, and I have a line of inquiry I need to pursue. We think one of the funding elements may well be continued following your meeting, so that things move on, with the second one perhaps being decided upon as a positive and negative in November, December. So I'm going to lobby on behalf of the board into that. So maybe the metaphorical check is in the post rather than actually it will be passed over today, but we're certainly taking this up because of the impact it would have and set us back locally. If not, clearly that's a consideration for our planning around future years and part of our prioritisation and risk appetite.
Thank you.
Any comments for the members of Population Health Committee? Thank you very much, and Steve, thanks to you and the committee and Jill as well, because I think we're absolutely right to have this as a standalone Population Health Committee because so many really big issues are beginning to come through. Thank you.
Yeah.
So,
sorry, Jamie, before we close, there was one question I wanted to ask around the provision of slush drinks.
All right.
That's noted. And can we be sure that we are not providing that in any of our premises?
We're working on that. We don't believe so, Jean, but there would only be Costa who don't. But we need to make sure that, you know, absolutely everybody understands, because unbelievably, we haven't had a Welsh alert. The alert came from Scotland. So Public Health Wales hasn't issued anything, but we have had this forwarded to us, and it's basically glycerol drinks. So those slushies that you find in leisure centres, iced, and so, you know, ice cream vans, things like that. Less regulated, I guess, sectors. If children under 10 consume them, they can become quite ill, and there have been hospitalisations. So it tends to be the less regulated sectors. The leisure centres, obviously, neglect is you know, something that to also.
I just wanted to be sure we're not offending in any way.
So, Jill, can we ask if you follow up on?
Yes, we're
outside,
Devon and I are working on that.
Just if you can send a note out, we can note out outside of the meeting.
And
Thank you
Jan,
very
just to say, I need to go meet new deputy. Can you just provide them? I'll bring in that.
Oh, yeah, okay. Thank you very much. So, Marie, we do move on then now to planning and partnership. Gives the board a really comprehensive look into all our different aspects, planning, partnership, and our commissioning role as well. So I'll hand over to you.
Thank you, Chair. And again, this is a long report with quite a number of appendices. So apologies to colleagues for the volume. We do try to keep it as concise as we can, but you'll appreciate that the portfolio is quite extensive. So what we've tried to condense in the summary report is an overview of those key areas that sit within this executive portfolio. Most of the reports are for awareness and for board's consideration, so that you are cited on the planning activities that are being undertaken. That I think there's only one item specifically for approval, which I'll get to, but I'll just quickly provide a canter through and an overview. And if there are any questions, then I'll be happy to go back and provide you with any details. So just in terms of our wider strategy and strategic programs and corporate planning, you'll be aware that we launched the organisation strategy at the AGM this month, I'm ahead of myself. And that provides the anchor framework for the next big piece of work that we are doing with all of our key stakeholders in developing a refreshed clinical services strategic plan. And I emphasise the fact that it is a strategic plan because we anticipate that we will have more detailed service-based plans that will then be taken forward under that strategic clinical framework. That provides the anchor point for our services development. Really quickly, and it's a point of detail, but one that I think is important, we have formalised the benefits realisation mechanism as part of our business case process and refreshed our business case, internal business case management and assurance process to ensure that benefits realisation now is considered as a formal part of our process. And that's in response to audit recommendations, but also it's good planning practice and something that this board was keen to see reflected. Planning maturity matrix is something that Welsh Government have asked us to include in our assurance process, and something that we will bring back for board's consideration in November as part of a escalation requirement through our escalation process. Our annual plan, colleagues will be aware there has been considerable correspondence between us and Welsh Government to confirm our position for this year, particularly in terms of our financial delivery, which is a key component of our annual plan. I think we're getting to that point, but we're also now needing to make sure that we're on the front foot for next year, and that the significant activities and planning assumptions and principles that underpin our recovery and sustainability work are embedded in our process for next year and going forward to take us to a position of both financial and service sustainability over the medium term. And that is a ongoing process, and I can keep board updated over the next few months, both through our formal updates and our development sessions. In terms of the partnership arena, lots going on in that arena as well, particularly in terms of the RPB, our West Glamorgan Regional Partnership Board. We have a number of core programmes that many of you will be familiar with. One of the things that we've done with our colleagues in local authority is work on focusing on our priorities, recognising that the programme and underpinning projects that are held within the RPB are really spreading us very, very thin. And there's some areas where we've agreed we need to focus our efforts and our planning and delivery activities. So those sit under communities and older people. So we've set up a very specific forum co-chaired by local authority and operational senior colleagues to look at how we strengthen the integration of our services in the community to improve our step up and step down services in a sense. So, and that work is happening alongside the community services review that's being undertaken specifically within our operational services, but reporting also across into the RPB to make sure that we are sharing information, are transparent in our approaches, and seeking collaborative opportunities to mitigate any implications for services out in the community. So we know that when we're looking at trying to rationalise and improve our service efficiencies, sometimes there are unintended consequences with partners. So we're very keen to avoid that as far as possible. Hence the approach and focus that we're taking under the RPB umbrella. The second area of priority is in our emotional wellbeing and mental health programme, where we are reforming and refocusing that programme at the moment to focus on working in partnership with our colleagues in local authority and voluntary sector to support the redesign process for our mental health transformation programme. So that's the vehicle that we're using to drive that in a collaborative way, which is critical to ensure that we get the pathway and service improvements in our mental health service provision, as well as some of the urgent and immediate environmental priorities that we've identified. And the third priority that we are driving through the RPB is looking at how we can improve our collective commissioning, particularly around long-term complex care. And for us, that means CHC. Again, lots of work that we're doing internally in terms of our recovery and sustainability priorities to improve and get better value for the CHC services that we commission. And we're very conscious that we do not want there to be unintended consequences on our partners in local authorities. So we are picking that up under our third priority area through our commissioning programme board, and really good engagement under all of those. So great progress. Public services boards, again, I won't go through the detail, but again, you can note some of the areas where we're working more closely together to ensure that where we've got areas of shared priorities, we're joining up our processes. We also have quite a comprehensive report and set of appendices which respond to the Future Generations Commissioner's report, which was also underpinned by the Audit Wales report, with a suite of recommendations for all stakeholders, but some that related directly to the health board. So we have done a report, a full report on where we are as a health board, and also included within that the responses back to the Future Generations Commissioner, which we are asking board to approve. I don't think there's anything controversial in there. I think we've got a good grip on where we are and how we can continue to engage effectively. In the regional partnership space with, we've also got an appendix in there with our most recent up-to-date report on the partnership with our Health R colleagues. And again, there's a range of us involved in that programme of work, and we can take questions on that if need be. Regional partnership with Cardiff and Vale continues in areas where we have some of our most challenging partnership services. Probably two things to note from a board perspective. We now have a formal signed off memorandum of understanding, which from an audit committee point of view is a big tick in the box and has taken some time to secure. That's now formally agreed. And there is an alert around the blood and marrow transplant services, where currently the Cardiff and Vale are our lead partner, and there is an accreditation visit pending from and who you speak to, Jackie or JC, who are the accrediting body for the bone marrow transplant service. In the event that that accreditation isn't forthcoming, that potentially has an impact on us in Swansea Bay for some of the services that we provide in partnership with Cardiff locally in Swansea. And we are looking at mitigation arrangements that may be required, contingency plans that may be required in the event that that accreditation is not forthcoming, but we're working closely with Cardiff on that. From a commissioning point of view, as you can see from the report, lots going on in that space. I've referenced CHC, lots going on with our RPB colleagues internally and on a national level as well. And also an update on the services that we commission through JCC from a specialised services point of view, and also looking at ambulance performance and delivery issues. And we are finally coming to the end of our voluntary sector recommissioning process, stage 4. I think it's been a journey for everybody. I can bring back at the conclusion of the process, which will is happening now actually, a fuller report to board, or we can do it in the development session if one would like, just to understand where that's got us to and what benefits we are hoping to secure collectively, not just us, but our voluntary sector colleagues and our population as a result. The Area Planning Board, which has been the subject of much discussion of late, just to flag and raise to the attention of the board, we have the publication of the Drugs Commission report happening next week, and that coincides with a partnership day that's taking place with all senior stakeholders across all the partners in the Area Planning Board. The Area Planning Board, for colleagues who may not be familiar with the term, is quite a loose definition on the face of it, but actually it relates specifically to partners involved in the commissioning and delivery of services relating to substance use, so drugs and alcohol in particular, but more broadly than that. So the collaborative, the Area Planning Board is a collaboration of partners to commission and improve the delivery in partnership of services for that particular client group, and that's across the Police and Crime Commissioner, Her Majesty's Prisons, South Wales Police, our services from a mental health and substance use perspective, and quite a range of substances in the voluntary sector that are commissioned by all of us actually for particular areas of support, both clinical and non-clinical. So it has been quite a hodgepodge of contracts and services across a whole lot of partners for the same population, which is what stimulated the stepping up of APBs as a partnership principle all the way back in 2010. So I think we are now getting to a point where those partnership arrangements are beginning to really mature. It is a governance challenge and one that we are well signed and well briefed on. But we are now beginning to move into a place where we have a genuinely integrated approach to alliance commissioning as an area partnership board. And that is now beginning to get to a point where we can start to tender. We are about to tender for services, and also to work with our stakeholders and most particularly with our users with lived experience to come up with a really robust strategy for service delivery. There will inevitably be a bigger demand than the capacity that we have available to us enables us to meet. However, we stand a much better chance of bridging that gap by working in partnership and reducing duplication and bringing service providers, commissioners and users more closely together. So a lot going on in this space. A big event next week, as I say, the Partnership Day, to look at how we collectively input and strengthen the draft strategy. And no doubt I will be bringing further information back to board as that develops. Finally, just to conclude, again, there's a comprehensive update on where we are in terms of our sustainability agenda, particularly in terms of delivering on our emissions and our adaptation plan. There's good news and bad news. Bad news is our emissions are going up. We know that that is difficult to control. The good news is where there are opportunities to adapt and deliver improvements, we are perceived by Welsh Government, certainly from a health perspective, to be well ahead of the game. So some really good work in that space. And last but not least, emergency planning, resilience and response. A quick update there on activities and deliverables over the last couple of months. One thing to be aware of is that we are in the middle of a we've just started a national pandemic training exercise called Pegasus. A number of us were involved earlier on this week in one of the first live play days as House Board Gold, feeding into the SCG. Jill is chairing the next SCG next month. So actively involved and engaged, and we'll be happy to brief board on the outcomes when we have some.
Well, thank you. Thank you. You can now brief. There's a number of questions around the timings of some of the actions set out, and Marie, there may be too many for you to actually go through and give us the timelines against all the points that independent members made. Because you could do that outside.
Absolutely happy to.
Please.
Yeah,
thank you. That would be really helpful in terms of that. Jean, please come in.
One, because I'm a numpty, what does the acronym CEMT stand for?
Oh, do you know, I thought we got rid of all the acronyms. It's the Chief Executive Management Team. Like that. It's the at national level, the chair of the Chief Execs group, where the Chief Execs all get together for NHS.
Okay, and then my other question is around, on page 9, you talk about the various references to the NHS Wales Joint Commissioning Committee, but when I was reading it, given the challenges in cancer care that we have, are we fully appraised of ongoing costs in the provision of the service, as well as the frustration caused to treatment delivery? I mean, you've mentioned in there prostate cancer, PET scans in South East Wales due to the radioisotope production, etc. I just wondered if we've a handle on both the costs and the frustration to patients in terms of their treatment.
Do you mean specifically for PET scanning or more broadly?
I was looking at it more broadly, given the read of your paper.
Yeah. So that is a big question that kind of takes us back to the original discussion we had at the beginning of board, which is the way that we need to try and design a service model that is affordable over the longer term is to improve our screening and upstream intervention with cancer services. We know at the moment what we've got is good. If we carry on with the treatment-based response model, we are already in the territory where it's more than we can afford. So we know, for example, that our cancer centre services, when you look at what we're trying to do around SACT and radiotherapy, we've got a demand that's bigger than the resource envelope that we've got. So we have to look at how we can improve our earlier interventions to turn that down, and look at how we can improve pathways so we become more efficient. But that at the moment, that's kind of like an add-on to the kind of the planned care programme. So we've got to take a much more structured approach to that, and in collaboration with public health as well.
Just on the radioisotope issue in particular, that probably is one of the most frustrating thing for patients, because it's generally short notice that we run out and we've got to cancel diagnostic investigations. So we try and we probably fare a bit better than other health boards, and that it's a national, if not a UK, shortage of that product. And we work really hard to try and make sure we've got enough resilience in the system to manage those diagnostics. But that's normally a short notice cancellation for patients when it does go low, that we try and manage and engage, make sure we communicate well with patients. That's where the frustration bit that we really do need to manage better.
Dan, I'm sure you'd want to come in, because one of the things you're doing, aren't you, through the allocation efficiency, you know, how much are we spending on cancer services, etc.
Yeah, I was going to make 2 points. Thank you, Chair. So one, Jean, was just around the contractual mechanisms around JCC. They're probably some of the most live, sophisticated contractual mechanisms in Wales. Others are more antiquated. It doesn't mean to say that the costs truly represent the provision. So we're doing some work on a specialty by specialty basis to that. And I could probably take a more detailed briefing offline, Chair, so it would be helpful. But good to understand that we provide £150 million worth of JCC services, and we give 144 million in. So the pot works, the pot circulates, but clearly as a provider, we need to make sure we're recompensed for patient movement across that. So it does work, but there's nuance and there's more to do to make that more interesting. And in terms of the allocated work, absolutely, Chair, we'll be looking at full pathway costs, so programme budgeting, which is the main tool for this, albeit it's very retrospective. Gives us a sense of the distribution of resource in a different way to the way we traditionally look at it, because we look at service groups, we look at corporate directorates, we add it all up, we assess the problem. But we have got other methodologies to look at how those main sort of programme budget areas are spending. Cancers in there, musculoskeletal, cardiovascular. So there's a rich vein of information there. We'll get the 24-25 ones in October. So that's the level of lag, but they're based on the accounts. So the accounts are produced and then we do the machinery for the costing, but it'll inform that process.
Would it be helpful to have a briefing outside the board, a more detailed briefing as Darren has outlined?
Yes.
Yeah, so we can take an action on that. Deb, did you want to come in and add before I bring Richard?
Yes, thank you, Chair. I just wanted to join those two bits up and bring it back to the previous conversation we had about patients presenting earlier. Because obviously the later patients present, the more expensive treatments we have to levy, and the more successful we get in that space means we're going to be doing more of those treatments, which costs the health board and a lot more from a financial perspective. So the more we can encourage patients to present earlier, the treatment options are more varied, generally cost a lot more to run than the surgical and the high-end therapy interventions that we need to do because of the late presentation. So it's joining all of those things together to make sure that we engage more with the population and get them present earlier to the primary care.
Thank you, Deb. Richard, please come in.
Thanks, Chair. Something that jumped out at me in the paper, there's a heck of a lot in there and there's a heck of a lot of ground being covered. But given the conversations we've had today about the long-term horizon of Gatwick, for instance, and the population health elements we discussed earlier around the environment, housing, etc., I really welcome the words in there about the local development plans, because on a number of occasions we've been approached about individual sort of housing developments and such like in terms of putting comments in. But I think engaging with the local development plans really gives us the opportunity to get on the front foot there, to be talking longer term and to really influence how the community and the placemaking agenda shapes up. So I think it's something really positive.
Yeah. Please come in.
Thanks. It was really good to see the benefits realisation framework now being incorporated into business planning. One question on timelines that I had for the plan for 26-27. Obviously we've got a hugely difficult financial context. Abby's alluded to the fact we're going to have to drive through organisational changes to operating model, etc., and all that while maintaining, improving quality, safety, performance. It's huge. So I just wondered about the timeline of that. I know it was launched on the 3rd of September. We really do need to be in a position of delivery by April the 1st. So I'm just wondering what we're looking at, what's the timeline for that really? And as a second question then, I was just wondering, I mean, we've got this massive issue still with pathway of care delays, which I know we've seen improvement in, but I was just wondering, looking at the role of the RPB, we're still seeing delays in assessments, we're still seeing delays in those community care packages. Just what's the role of the RPB? Are they proactively working?
So I'll come to that second, and I'm sure Deb will want to add to that as well. In terms of timeline, if it's helpful, I can bring into Performance and Finance Committee a detailed critical path that takes us from today to the 30th of March when we submit the plan. So we've got that drafted up. We're taking that through management board because we changed the approach slightly this year, partly in recognition of the work that we have been focusing on with the Recovery and Sustainability Programme, because that has to be a fundamental consideration, and we have to think about how, for the annual plan next year, how do we make sure that that is reflected appropriately, and workforce assumptions around that, and then the impact in terms of performance and delivery. So it is quite an operational approach to next year in terms of the annual plan, which is why the conversation earlier on is so important about making sure that we have got that longer term horizon context still framing where we're trying to go. So there's the bit that you're interested in, Pat, which is how we're going to get to a fully worked up plan by the end of March. We also need to make sure that we've got context. So that's what we're working with at the moment. That's what's been. But we have got a critical path for the plan production, which happy to walk colleagues through in more detail to here. In terms of your second question around the clinically optimised patients and delays in being able to discharge patients into the community, that has been a very hot topic all year. It's one that has probably been the main focus of discussion in the older persons and community group. So how do we get the integrated discharge hub cooking on gas? How do we get that properly organised and resourced? And we all know we haven't got any more money. So how are we going to commit to making sure that that works more effectively? And Deb and I have just this week, I think, come out of a meeting where we've put some really firm commitments from the health board perspective in on the line to say, right, we now need to have a commitment and a timeline. I think we're at the point where we're going to have a commitment and a timeline and trusted assessor, and having a trusted assessor panel that, and we're as bad. So this isn't about us pointing the fingers at local authorities saying, you're not stepping into this. We know there are areas where we haven't stepped into. So we're using that group, that integrated group, which is chaired by one of the directors of social services and co-chaired by Craig. So we are pushing that quite hard, and both Deb and I were in that discussion at the forefront of it, making that point loud and clear.
Deb, do you want to add on pathways?
Like I said, the Grand Chair, to be fair, it is the main focus of all the conversations we have with directors of social services, and they are engaged.
Yeah, thank you. So Steve, do you want to come in there?
Yeah, thank you. So Murray, a couple of points. You can't, I'm looking at you on the screen. So that's you in pink. The Pan Cluster Planning Group is not mentioned here, which is good in a sense because they're not a partner, they're part of us. But they will be setting off, they've got a meeting next week, they'll be setting off on their 26-27 IMTP planning. And we're obviously doing our planning now. And now the twain will meet, or will they? Will they be properly integrated into our plan?
Yeah. Yes, absolutely. I think the PCPG's role in both operational and strategic planning in the broader organisational context has been a bit underdeveloped. I think as a cluster group, they do amazing things actually. So and some of them are national exemplars. They're brilliant. PCPG will have a critical role in the kind of looking at the vertical integration of how we really start to strengthen service delivery in our communities without having lots of pop-ups, as Deb calls them, and handoffs between first and secondary care. And then we need to work out how the RPB planning work again more closely aligns with some of the community redesign work that's going on, both on the immediate priorities and the longer term. They have tended to work a bit in parallel. There is representation from PCPG in RPB and vice versa, but I think it's a bit weak. So there is absolutely an opportunity to strengthen there and capitalise on the really good work that's been done in the clusters so far, and look at how do we roll it out. One of the opportunities as well is to look at how do we develop an integrated infrastructure plan to support the service models that we're describing in our, for mental health services for older people, etc. And in the primary care model, how do we start to develop an infrastructure plan that supports those in an integrated way rather than separate practice plans, mental health team bases, etc. So there is an opportunity, I think, to use that as a vehicle to help pull that more closely together and align with that placemaking agenda that PSB's have as well.
And the other bit, and you touched on the RPB, you say that the executives involved in the RPB will be, because there's so much going on, we'll be focusing on some priorities, but they're not specified. So what do you see as the priorities?
So the three that I kind of mentioned verbally in that update, so it's about so looking at the communities and older people's group driving the integrated services planning, starting with genetically optimised patients, integrated discharge, trusted assessor, so supporting that pathway, but also from a strategic point of view, picking up this integrated community system planning that is being pushed out hard now by Welsh Government, and that's where the PCPGs need to interface as well, because you can't do integrated system care modelling and planning without PCPD's been party to that discussion. So there's a bit of work for us to do there, and we've got a session coming up, or we've got a session with the Cabinet Secretary on the 14th of October, but we've got an internal discussion where we're trying to bring colleagues together to talk about how do we do that without trying to put a whole new structure over it, because we've got lots of groups, lots of fora. We can't afford to put any more in. How do we strengthen the interfaces and give some clear directions so that they're doing that? So that's the older persons group. The second priority in the RPV space is the mental health transformation in the community, working with through the emotional wellbeing and mental health programme. So we've refocused that to focus on supporting mental health transformation service redesign that is being led through the health board, but being delivered obviously from a service planning perspective is through the RPB. And then the third one was commissioning and CHC in particular. So we're trying to drive that through health board from an R&S perspective, but it inevitably requires engagement with local authorities, because we don't want to just be cost shifting. We want to be looking at collaborative solutions that benefit us as a health board in terms of getting best value, but also solve a wider problem, which is around commissioning and delivery of long-term complex care, because we have problems in that we trip each other up by trying to pass bills to each other. Commissioning perspective, not helpful, just results in lots of disputes. But we also have an insufficiency in the market because we can't commission because the care that we need is available locally. So there's an opportunity for us to look at how do we incentivise that and how do we potentially develop alternatives together if they're not available locally. What is that market gap that we need to look at how we try to bridge? There's good early shoots in that area. We've managed to resolve a whole backlog of disputed invoices, both in PCT and mental health. So we are going to clear the decks a bit, but it's a lot of work.
Thank you.
Steve, I think you'll be at 14th of October. This is Chair's Vice Chair, etc. Or are you?
I'm going to be in Menorca, so unfortunately not.
They have teams of them.
I said to Sandra, if you can get me video.
Okay. Right, thanks for covering all that around there. So if we take the recommendation, just to tweak a few other things really, given our conversation. So we've obviously considered where we are in this year's plan, and we're very clear that we are going to have to undertake a further prioritisation process between now and the end of March to deliver both our savings plan and the best year-end position we can then. On the second one, Nuria will ask me to say that working with the PFBs is statutory. So we don't have really, so we reaffirm our commitment to doing that to the best of our ability. And then I'm sure we want to support all the plans and actions to strengthen our strategic and partnership commissioning arrangements and really acknowledge the sheer breadth and depth of that commissioning role. And please thank everyone who undertakes any form of commissioning on our behalf.
Or two of them.
Not. But they are hugely productive. Please thank them. So, and then we have increased awareness now of our carbon emissions and the work we have underway to minimise any increases. We've looked at and supported the priorities in the EPRR programme, and are we in a position to approve the response to the Future Generations Report 2025? Very much.
Thank you.
I am now going to propose a slight adjustment to the agenda and suggest that we take 4.3 and then the finance report and then we break lunch. That seems to flow better rather than stopping after the update and the advice from PSC Pat. I think we should then flow into the finance report. Is that okay? So we'll come back to 4.1 and 4.2 after lunch. Does that make sense? Thank you. So Pat, shall I hand over to you then for PFC updates, and then Darren will follow on with the finance report. Pat.
Yes, sure. The alerts that we've been seeing really over the last 3 months, because we had a meeting earlier this week as well, of course have been about the financial position, but I think that's been superseded, so we can address that as part of the commentary on the financial plan. The other alerts were on service group financial positions, and we've looked at Morriston, Talbot Singleton and PCT over the last 3 months. all of these about a lack of sight to full savings delivery, significant shortfall coming through on that, and variable pay levels running way too high, often at the same levels as they were in 24-25. We have seen reductions in Morriston, but not in line with the cap. So those are the two big issues on all service groups, really. I mean, the mitigation in terms of those is obviously the emergent savings plan. And it's going to be good to see when they start to translate into service group plans. And I think possibly we need to pick that up as part of it. In July, one of the alerts was ongoing concern around stroke performance. And really was the continued absence of the stroke on call rota. And that was discussion. So significant risk to service continuity and patient outcomes were raised. And part of the mitigation of that, Deb, you were looking at repurposing 2 unfilled acute care positions posts that were vacant due to recruitment challenges, and looking to sort of use those to support the stroke rota. So I don't know what's happened with that. I know you were those were the alerts really that.
There's no further update on that one yet, Chair. We're still working through it from a financial and recruitment perspective.
So Fran, did you want to set out for the board the advice from PFC in relation to where we find ourselves currently now on the financial position?
Do you want me to do that before or after?
Oh, do it after, yeah, do it afterwards then. Yeah, that's fine. Thank you. So Darren, we'll hand over to you then for the financial report and then PFC's advice.
Thank you, Chair. There's a detailed report in the pack which I'm sure colleagues have read. I'll pick up the salient points.
Yeah, it would be helpful because it went out late. So if you can just make sure all the salient points are covered.
I'll do my very best. Thank you. I'm happy to take the questions then. The report is the routine paper where I need to formally report monthly performance to the organisation, but also then section 6 of the report is a specific addition this month. And this section updates board members of the ongoing position in respect to the Health Board's savings delivery in the context of its submitted annual plan. I'll do the month 5 bit first. We're going to keep on from that. I'll spend a bit more time on the financial plan and savings. I think that will aid Pat with her response from some of the work we've done this week. So the detailed financial position has been reported routinely through the months to independent members, and you would expect Performance and Finance Committee gave that good scrutiny on Tuesday of this week. Section 3 of the report before the board today just reminds us of the submitted plan and the need for the organisation to deliver £55.4 million worth of savings as a minimum to achieve a deficit of 58.7. If I just run us on then to section 4 of the report and call out some of the key figures for the month 5 revenue position, you'll see that the Health Board reported a 5.98 million deficit in month 5. And whilst that's our best month's performance to date, that's clearly still a very challenged position. But that takes us to 37.8 million overspent to date. And that is therefore a £13.3 million gap from plan as currently constructed. Of interest and of specific relevance to what I'll say later on, the savings gap is nearly 16 million. So as with 13 million off plan, savings is a substantial driver of that. If it wasn't for that, we would be marginally ahead of plan in terms of operational performance. And graph 2 over the page, and some of the page changes on the screen as to what I've got in front of me, but page 6 just shows on the blue bars there increasing savings delivery, our best month to date, but still a substantial distance to go. And I think it's pertinent to highlight, Chair, that we've only got £21 million worth of headroom left, having only 38 million to date. So our next 7 months can't be more than 3 million overspent each. And our best month to date has been 5.98 million. So the scale of the challenge, the pace and the gradient of that over the latter part of this financial year is clearly we have a significant challenge to it. Pages 7 and 8 of the report provide a breakdown of the detailed financial analysis of the variance of the Health Board for in-month and for the year to date. Those, but they're just to inform. And from a capital perspective, from a savings perspective, I've set it at the top of page 9 the 3 key elements of how we will address the 5.4 million savings gap. And I will talk about that in more detail. Just touching on capital, the capital current overspend is £800,000. Some of the detail of the streams is separate below. We've driven good values for some of our contract, or we are in the budget on lots of imaging work that we're doing part of the replacement programme. So we are confident there that we will maintain the capital resource limit. We're in active conversations with government about how we might manage slippage there, both nationally and locally. And I'm also pleased to report that this is a single line on the report that I'm hoping to conclude this week, the land transaction at Morriston. We'll see a capital receipt for us, but actually will bring some of the land that we discussed earlier, the 55 acres, into better adjacency for us. That's only taken me 12 years, Chair, but I'm very much looking forward to seeing the final bit of paper on that from when we acquired the land very early on in the process. And from a balance sheet perspective, again, the detail is there on page 11 of the report. I will just draw a minor point on cash. We closed the end of August with a heavier cash balance we would expect, with 9.8 million. That's because we were expecting to make some payments around some litigation claims, and those payments were subsequently made in September due to delays that weren't of the health board's making. But very importantly, that table on page 12, which is the year-end cash deficit forecast, maybe expect this at this stage. The deficit in our cash balance is likely to be the scale of our reported planned deficit of 58.7 million. We are having discussions with Welsh Government, as are other boards, but there is no certainty of strategic cash this year, which could very much challenge us in terms of meeting our credit requirements in the last month of the year. That's the same for all health boards with deficit positions, and I will work on behalf of the board into the discussions to make sure that's addressed and or managed through mitigation, which will be quite challenging for us, but it's the first year that the scale of that has started to impact some of the choices we may make towards the end of the year. And I can pause there, Chair, because that's the month 5 element, just the questions that, or I can go on to the savings in the plan.
I'll just ask, are there any questions for Darren on the month 5 position, Darren's analysis? Thank you, you've sent that out very clearly, Darren. So do you want to go on to?
So section 6 of the report, which is the addition this month, updates members on key points arising from the conversation that the Chief Executive and I had with Welsh Government officials on the 11th of September, following the special board, and the construct of the discussion of the special board we took into that discussion. The details of that briefing are there under 6.1 of the report. Since then, on the following Friday, we have had a response letter from Welsh Government as promised. That letter is appended as Appendix 3 to this report, and the key paragraph in that letter relates to some of the discussion we'll be having today around how we are working the ongoing closure of the savings plan. 6.3 of the report just reminds us of the high-level plan, and board members will be aware that we took from the meeting a plan which sets out how we would deliver 55.4 million to meet that requirement. And when the Chief Executive and I briefed Welsh Government colleagues, we were able to describe that section B of that, 36.6 million, so 33.6 million, and 6.8 million of section C, which is the work we've been doing on the executive-led themes with the organisation, so totaling 40.4. We had a high degree of confidence in the delivery of those, and we were still actively and live at that point in time having further discussions about the 15 million. And I would draw board members' attention to the table at the bottom of page 17, as it's presented on mine, with 6.4, which just shows those key elements then that make up that 15 million, and I will address shortly the work we're doing to close that off. 4.3 million are currently on savings trackers as read, so we can't claim them as savings just yet. All of this was debated in detail at Recovery and Sustainability yesterday afternoon. 1.7 million in pipeline, the variable pay controls of 6.3 million, some reconfiguration of planned care resource to 750,000, and then potentially just bearing down on some of the non-pay expenditure in the next 6 months of the year to release a further 2 million. And it was that 15 million we were able to describe in some detail to colleagues of Welsh Government, but at that point in time 2 weeks ago, couldn't give delivery confidence on because we were still working through that, and the mechanisms to give that delivery confidence were not with us. There's a further table then which crosses pages 18 and 19, and what that table is just expand the elements of that 15 million to give some sense of what the composition is. Whilst I won't go through the detail of that, there is increasing certainty on elements of that 15 million, but we need to drive the delivery of those. So what's really clear from where we've got to in that regard is the 55.4 million pound savings plan is visible. All the component parts are known, but it's complex, and that is stretching for the organisation in terms of the ambition, the breadth, and the numbers of people involved to help us get that landed. And we need to work through that in a very systematic way, and are doing so. The detail of this plan is understood in the organisation and by the board. But very importantly, and this has emerged very, very clearly in the last few weeks, is that our ability to deliver the plan rather than describe the plan is largely and almost exclusively determined by the level of support, capacity and capability the organisation has to drive change of this nature, both in the immediate term and over the longer term. And I won't steal Pat's thunder there. The committee have been very clear to me and very helpful in the regard of describing that. And to my comments earlier and to this, that level of support, capability and capacity needs to stay with us over time, and that can transition into a health board proposition to deliver that. But at the moment, that's currently with us from an external source. That external source of support is due on the 3rd of October and is proving beneficial to us significantly. As an organisation, if we drive the change agenda we've discussed across some of the population health areas, our partnership agenda and the clinical service plan and longer term strategic plans, we will need to be geared up to do that with the right resource, skills and capabilities in the organisation. I also wanted to add there that in terms of perhaps some of the aspects of our underlying deficit, which is ongoing work with Deloitte at the moment, because it's very complicated. Clearly, we're starting to see some emergence of the fact that our acute hospital site model is 3 main hospitals for us. If you look at that across a population basis, it's more like 1.5 or 1 would be expected in a population of our size, recognising we have got tertiary services, and that we need to allocate our resources differently, and that this is part of a 3-year recovery plan from now, for which we would probably be wanting to start conversations with government about a strategic financial support model, whatever that would be. I think we need to discuss that in clear terms, off a really strong platform this year, which gives us the right to describe a future direction of travel where we would be confident and we can articulate to our scrutiny as a high degree of confidence in the delivery of that 3-year trajectory, which I know is our aspiration. The last section of the report just starts to draw out some of the risks. I know I've been clear on this before, but I think it's important to be clear again today. That 55.4 million will deliver the 58.7 plan that we submitted in March. There are new emergent risks through the course of the year, which I've listed, that will require us to mitigate those. Some of those will be within our own gift to mitigate. Some of those will be requiring mitigation, perhaps in partnership across Wales, working with other health boards or government, and lots of things are live in that regard at the moment. But from my perspective, and to be very clear to the board, unless the mitigation is action-based or choice-based, we will not be able to cover it off because I don't have any other resource available to me, nor is there other resource we're being told in the REPBARS, the Welsh system, to offset any cost that could emerge through those risks. I think that's probably about as far as I wanted to go, apart from just sharing my thanks to board members, because we've all spent a lot of time on this in the last few months, specifically in September through the special board, the PFCs. We've had this week the independent member briefings. Clearly, this is part of our collective agenda. It's understood collectively, and there's some of the challenges in addressing this collectively shared. And I'm just grateful for the time to be able to have those conversations to help shape our positions.
Thank you, Darren. Pat, I will ask you to come in now if you could give the PFC advice.
Yeah, we've had obviously a lot of enormously detailed conversations in this. We asked Deloitte to attend for the last meeting. We wanted to get their views as well, so they attended. I mean, first we've got to say that we really welcome, we've got a significantly more robust plan for the delivery of 55.4 million, both in the current year and recurrently, which is critical. And we've got to really acknowledge the scale of that achievement, especially as it comes on top of 40 million delivered recurrently last year. So if we can get this through, we've delivered 95 million pounds worth of savings over the 2 years. And that's, you know, that recognition. It'd be good to see what other health boards have done over the same period. The executive-led savings programmes have been formulated by the exec with support from Deloitte. 6.8 million in the current year, 29.5 million as a full year effect. Those themes now have PIDs in place for each area with a breakdown of savings targets, clarity on the high level actions with milestones and the risk and mitigations. It's great to see this kind of discipline in place at this point. Our main concerns, I mean, Darren has alluded to this, are about delivery confidence. We questioned our ability to move from plan formulation into the delivery of multiple actions within the timescales required to deliver these savings in the current year. But not just that, you've got to address these financial challenges recurrently.
So, change in health board policy, processes, approach, behaviours, they're all going to have to be fully embedded for sustained delivery in 26, 27 onwards. Then we've got further savings requirement to deliver that 3-year trajectory over the next 2 years of a further £77 million of the savings. And on top of that, we've got risks facing us in the current year, which we won't be able to address in the current year. We're taking that forward, which is another 25 to 35 million. So we're looking at in excess of 100 million over the next 2 years. And we can't, we've got to face up to the scale of this really. So, significant service change is going to be required. Whilst doing that, you've got to improve operational efficiency and effectiveness, improve service performance, quality. It's huge. We then asked Deloitte really what their opinion was, and their support is due to end on the 3rd of October. They do see a risk in terms of our own internal capacity to drive the delivery. They did echo that. And to importantly maintain enhancements to the grip and control over areas such as variable pay, which we found so problematic over the last months. They are very impressed by the scale of buy-in and the pace of planning from the executive. They really stress that point. And now believe we do have a credible set of plan in place. But again, they did recognise the scale of operational pressures faced by the executive and service group leaders, and they saw that they now going to require really extensive programme management support to drive those plans through to delivery. So we do need to hit the ground running, and we're nervous that our kind of performance will start to fall backwards or plateau as we go into the next 6 months. So I think we very collectively gave a very clear view that programme management capacity and capability to drive delivery must be enhanced in order to give us delivery confidence of the 55.4 million. And to ensure momentum isn't lost, we would recommend that the services of Deloitte's Eye retained for an interim period from the 4th of October onwards. But during that period, I think the Health Board must make a rapid assessment of its own delivery capability and capacity, given the scale of change that we face, not just recovery and sustainability, but on a whole number of other agendas. So, whether that comes internally or we have to recruit, we really do need to face up to the fact that we need to enhance that going forward.
That's very sobering reflections from Performance and Finance Committee. I'll open it up more widely now. Comments, questions? Steve?
Yeah. So, to summarise, Darren, the 55 million of savings, it looks like there's a line of sight to it. It's going to be tough, but we can probably get it. But the risks that you mentioned, which aren't all now risks, many of them are actually facts. And you very helpfully set out a worst case, best case, and most likely case in there. And the most likely case, and you've said there's no mitigation as yet. The most likely case sees us needing to find another 30 or so million pounds in the next half a year. So there must be some, and you've alluded to ideas that are going around and some plans that have not yet been set out in a list of plans with numbers next to them. And you've had discussions with Welsh Government, but this board is going to be responsible for delivering this deficit. And we don't yet see where that mitigation is going to come from. So very soon, I think we need to see that, some ideas with the numbers that they can generate. And I would think in the next several weeks, next few weeks, I would say, we need to have a good understanding of that. And I would just repeat what Pat said. It was clear to everybody in the PFC and the wider IM discussion that we had on Tuesday afternoon that Deloitte should be asked to stay. If we ask them to stay soon, we will get the same team that have been helping us for the last several months. And they're available on the 6th of October to carry on. Even if that funding is not available from Welsh Government or we have to wait for approval, we can take it. We should take it at our own risk. That's money very well spent, I would think. So that's
Steve, Darren, do you want to come back on that point?
I'm happy to go back to what's said, that's okay. So I've recognised this as a board decision. I have asked Deloitte, would the team still be available should the board make this decision? And the answer is yes, but we need to know quickly. So that continuation and that acquired knowledge, momentum and relationship could continue. I would want to robustly test that in terms of our procurement position and make sure it's very transparent and compliant for us to do so.
Is that within a specific timeline then, Darren? It would say from the 4th of October on until when?
I've asked for scenarios, Chair, because I'm not sure what the quantum of cost would be. And I think we need to make that decision in a very prudent way rather than principal way. So that.
Thank you.
And just on that, it gives us the opportunity also to just be really clear on the scope, because some of the things that they're doing will be a piece of work that comes to an end. So the work, for example, on the underlying deficit and what the drivers of that, well, that's a bespoke piece of work. So it will enable us to, and I know, Darren, you're looking at in terms of the scope, actually what we need to consolidate and enable continued support with the very clear requirement to get absolute traction and delivery on the things that we've put into the plan.
It would be a continuation and evolution, exactly as you described. Just if I may answer the question mitigations, Chair. Outside the public boards and through just scoping, we have developed a list of what could be very, very difficult service decisions and choices. Abigail and I were able to discuss that with Welsh Government last week. So there are aspects that are being worked up. And to your timescale, Steve, we can do that. We should bring that to the right governance again to share that. And I know the board's been concerned about just making sure we're really clear what those choices could be, showing the benefits realisation of those, because they would be probably more impactful than some of the ones we've made today. And we need to very clearly understand the nature of the impact and the benefit. So we have got that list, we're working through, and it has been a number of months in the gestation because of the complexity of what we're doing. And that's part of future risk management.
And we talk about taking that forward as a matter of urgency. So we'll need to try and tie that down in terms of timeline, because if we're going to go to our government for strategic financial support, they will want to see a clear 3-year trajectory. That's what goes on. But we'll come back to that point when we get to the recommendations. I've got Rena, then Jean.
Yeah, I just wanted to support Pat's summary really in terms of where we were on Tuesday. In particular, I think it seems to me at the moment we've got to invest in having that capacity and capability in the organisation, because it's not just for this year, it's for the subsequent years, which Pat's just mentioned. Because clearly we need to get recurrent savings in the programme, and in a way, although it's reassuring that we have got some one-off savings that are assisting our programme, which we talked about on Tuesday, that isn't going to solve our problem going forward. So we really do need to get that capacity in now, and I would totally support that we need to potentially go at risk and invest to save, frankly, in having that capacity right now. Because otherwise, I do feel our chance of succeeding in this year in actually meeting the control totals is probably going to be, not as good if we didn't have that in place.
Thank you. Jean, please come in.
I obviously concur with everything that's been said, and the discussion that we had, or discussions we've had with Darren and Sam over the last number of months have been exceedingly challenging. However, we are all aware of what we have to achieve. We're all in this together with the staff who are delivering. And one of the things that I would urge Welsh Government not to overlook is this is a 3-year trajectory. And we have such a potpourri of, and I'm trying to put a nice phase to this, we have such a potpourri of a magnitude that many people in managing change probably never come across. So if you think about the organisational design, where we're at in terms of delivery, we're not compromising quality and safety for the patient, and we are not under any illusion whatsoever, and I think I speak for the other people on PNF, of what we have to achieve. Our commitment is there, but I keep emphasising we've got the 90 odd that we've already saved. We've got 100 in front of us. We are committed to get there, but we need the time and the opportunity to put all of the jigsaw together in order to deliver.
Eugene, those points are really well made, because we have always said we're on a 3-year trajectory. And we've made that clear time and time again. Other points, questions, comments? Martin?
Just Darren, you commented on the examples of we could be going down as a route of achieving the total target. What were those examples? Can you give us an idea of what they could be? You said you have ideas in hand.
It's probably a matter for a private discussion, Martin, just because we haven't, there are a list of quite challenging options, and we probably want to get that socialised with the organisation in a different way, but I can certainly share.
Martin, obviously you're new to the board, and what we do when we're still working things out, we take them in development sessions or in committee, because what we do have a public responsibility to do is not let hairs running and cause alarm unnecessarily until something's come up and it's not, it's fully cooked, it's not half cooked really. So that's why it's not that we will not be transparent, we will, but while we're working things out, that's why we don't bring it in public.
Yeah, just to add that, Martin, the kind of principles around that are areas where if you look at the kind of cost base, it is costing us more than you would expect for us to deliver, or they're in line with our direction of travel anyway around delivering services on multiple sites and critical mass. So the in a sense, the specifics we're looking at and testing, but the principles around those sorts of things, and that's why the work that the Deloitte is doing, and Darren's right, it is really complex. I was at a meeting on Tuesday with a number of chief executives from England. Wales system is really great in terms of it being integrated health boards, but when I'm talking to peers in England, there aren't many people who've got mental health, learning disability, acute care, the maternity and neonates, and so many different hospital sites, et cetera, that they are managing. So in terms of the breadth of things that we've got on our agenda that we need to transform and change, it's really significant. The important thing for me is around us being really clear that we know what our plan is and what our longer term vision, aim, and working back from what that looks like and how we can accelerate it. And Jan, I don't know if you want to pause for a bit and see if there's any final comments, because there's some concluding comments I'd like to make.
Tina, I just wonder whether you wanted to come in on the whole workforce agenda that's facing us in general terms.
Yes, please, Chair. So I've started undertaking a baseline and doing some benchmarking against other health boards, and obviously looking at similar organisations in the England system as well, just to see where there's potentially we've got different size and shape of our workforce compared to others. And is there a genuine reason for that, or is there an opportunity for us to look at different ways of working and how we might skills mix or look at different roles within those areas? So I've started that work. I've got a report going through to the Workforce and OD Committee meeting this month to set out my plan on a page, if you like, for a strategic workforce plan. And that will allow us then to identify those areas for transformation. And that will be brought back here, Jan, for the next meeting for discussion, if that's okay.
Yes, thank you very much, Tina. Thank you. That's a phenomenal piece of work that you have kicked off, and we're grateful for that. Are there any other comments or questions or points before I ask Cabby? Obviously, we're the chief exec and accountable officer hat on to give the board your advice.
Thank you very much. Yeah, thank you. And Pat, thank you for your comments, because in a sense, they very much mirror the points I was going to make, really. We made significant progress last year in terms of recurrent savings, as we know. Clearly, we recognise that we were slow to get the populated plan in terms of Q1 savings. So we are in a position that we're in. The benefit of having a strategic partner that can mobilise very quickly capacity. We will have pockets of it across the organisation, but organising for success is about how we bring all that together and galvanise. We've talked previously about board to board, what do you need at every level? What do managers need to be able to manage their budget and their workforce, and the patient experience and quality and all of those things together? For me, what we have had is a real check and challenge of how credible the plans we had and testing and taking off the table things that we're never going to deliver, And then really focusing and working through with us in very granular detail. So what are the plans and how do they transact through into the individual expenditure areas out in the service boards? And that bit of a challenging conversation. We had some challenging conversations in Recovery and Sustainability Board yesterday, but you can see it working right the way through. So where is the money expended out in our service areas? And we are making progress. One of the things they bring, yes, they bring the data and analytics very quickly, very fast. They bring the program project management, so you keep on the pace of it, the turning things. We're asking weekly turnarounds from our service groups and exec directors in terms of the updates, moving things along the pipeline. And I was encouraged yesterday, so the movement we've seen from the pipeline, from things that are in amber into green, red into amber, and then those that we've color coded as yellow. I know we should have chosen some other colour because we've got red, green, amber, we've got yellow as well. But all of those things, which are how the executive driven programmes will fall out, and getting the granular detail on exactly what that's going to mean for the money coming out of the system. So we're in a much better place. And Jan, that is really important in the strategic context because we know we're on a journey. I have sent round to you today the Auditor General's latest update on his review of all of their 7 health board accounts. There's a summary and it's really useful to read. But his concluding comment, and Darren brought it to my attention first, it was very timely to her. It was like, yes, spot on. Recognition that, and I'll just use one of the phrases that he used. We need much more fundamental and transformative approach to returning the NHS to financial sustainability. So there's recognition that actually underlying deficits are going out, and we have got to move much more quickly and much more into the space of more fundamental change and how quickly we can get to that. So there's the work on really good practice around efficiency, productivity, using our resource to best effect for today, but there's actually about how do we use the resource we've got available to the best patient outcome into the future. And we've touched on some of that. Some of that is beyond the 3 years because, you know, I would love to go, right, we're going to have our new mental health solution in place in 3 years' time so we can consolidate those boards. We'll take a step towards it with the interim. But some of that capital ask will take longer. But if we've got a clear vision of what that looks like, we can take that to Welsh Government, go back us. And the importance of where we are now is we need to give confidence to Welsh Government that our plan is really credible and that we are delivering it and that we will work that through and that we're committed to doing that and we will make that happen. And therefore, I really welcome the board's support with keeping capacity on board to enable us to do that. As I've mentioned, Tina and I are talking about how we could accelerate that organising for success programme for 2 reasons. One, we don't want uncertainty drifting on, but we have to do it right in terms of engagement and consultation, and we're just going to manage those timelines and tensions. But we'll look at how we can drive that through. And I think we have got a really clear narrative about what we're about as an organisation, where we see the opportunities and what we need to do. And some of those will be difficult things, and we need to reflect on service change and the importance of being able to talk to our communities around how both big picture and small, we need to change the way we deliver services. And there will be lots of opportunity for doing things very differently and capitalising on opportunities that we've talked about previously. You know, the digitally enabled, that's a really big thing. That's much more productive in terms of how we use our resource, our people and our buildings, but also actually what patients expect in terms of the way that they can access services. So I think we've got a really clear plan. The clinical services plan is going to be a key enabler in terms of how we set out where services need to deliver. Our partnerships with our 2 neighbouring health boards for different reasons that, as Marie alluded to, with Cardiff and Vale. You know, we have the 2nd smallest cardiac unit. Cardiff has the 9th smallest cardiac unit. We understand cost implications when you've got low volumes of activity, and in a sense, coming back to your point, Martin, that will drive some of it where we've got low levels of activity and a cost base that you need a critical mass. Where are there opportunities through that and driving that through? And again, there's nothing that's not kind of known in relation to that. There will be obvious things that come through. So I think we are in as good a position at this point as we can be. We are driving really hard, and we're conscious that next item on the agenda a little bit later on is about our winter plan, about making sure we remain resilient over the winter. But the work that Tina's doing, we need our workforce present, able to do the job that they're here to do. And we need to support. So the wellbeing piece around staff is really important, and how we enable people to be present and able to commit and on board on the journey around the transformation that we need to make. So from a chief exec and accountable officer position, I really welcome the support from the board. And I think hopefully that is a narrative that you recognise. I think we're in a really critical month. And Jan, you and I have been meeting with Cabinet Secretary, and I'm anticipating the new Chief Executive and NHS Wales Director General. I think it'll be her first day. So she will be warmed up in terms of our position, and I hope that she can see we're an organisation to back, because we know where we're going. We can demonstrate we're going to deliver, and we've got line of sight to a sustainable and recurrent position that delivers for our population and the wider communities that we serve. And we're conscious, Jan, that we've got a week's lead-in time to run into that meeting, so there is a lot of work. We're putting pressure on our exec leads, our service group, recovery and sustainability mechanisms to make sure that by the 6th we are in a really good position to be able to describe that to the Cabinet Secretary and the Chief Exec.
Thank you, Abby. And it just sets out, as I've indicated, those sheer scale, the breadth and the depth of the building challenge, which I think is, probably unique at the moment to the health boards across Wales, because I think Betsy's been here, but is moving along its trajectory. But I think from our perspective, the challenge facing us is the most significant, and we will need to get that across to the Cabinet Secretary and the incoming Chief Executive. So if we can move to the recommendation. So well, we acknowledge and accept, don't we, that we weren't in a position to approve this year's financial plan, and Welsh Government didn't find it an acceptable approval plan either. So month 5, some slight improvement in terms of how far we're off plan, but clearly we need significant improvements from now on. But as Darren said, we've 21 million worth of deficit left for the next 7 months before we exceed that 58.7 million. So can we confirm that the actions that are set out, they do give us that line of sight to get to the 55.4? They give it to us in terms of the formulation of a plan. Yeah, we contend and we can confirm that. What we have to be about now is actually implementing the gap to get there. And I think from everyone's perspective, delivery confidence in achieving this depends on continuing our additional capability and support from Devon. So I think we said we need to bring that in and continue it in the water model at our own risk, really. And then there will be due process around procurement and around the scope and the products that we would be expecting from that continued support. Is that okay? Everybody attend with that? And I think we are going to have to make that clear. But at the same time, as we've discussed, we also need to rapidly assess the way we build up our own capacity and capability, and particularly our programme management capability to support all the work through recovery and sustainability. And Abby, I know that you have work underway on that. And Darren, it's really helpful to have the schedule set out, best, worst and likely scenarios in terms of what is, I think, an unprecedented set of risks that have arisen in year. I don't remember anything this big of just popping up in year, really. And of course, the band 2, band 3 issue is significant across Wales. So we do need to make that absolutely clear to Welsh Government. And then, as we've discussed earlier, we are working at those different choices. So we need to do that as a matter of urgency. So we'll need, we need your advice on how we bring this back, perhaps through PFC in the first instance, and then to the full board. But if we can ask you if we can do that, because the scale of these changes and the need to set them in that 3-year trajectory, because as I said earlier, strategic financial support will only be on the table if we can demonstrate we have a plan over 3 years to get ourselves back to financial and service sustainability. And that's what we're about. And as we said, the commitment's there. We know where we're going. We need the time. but we need to convince Welsh Government that we can deliver. And we can. And we will. So shall we adjourn for lunch? And we'll come back then, say 5 to 1, please, and then we'll briefly leave. And Darren, thank you, Sam, and the minutes for everything you're putting into it. We know you're spending hours and hours, and we are so good. Thank you. Okay, break for lunch now then.